Jay called Presidential Committee. Yeah, sure. Yeah. She's now getting more and more important. She's chairman of but next year she will also in COEX, a huge company. It's very important.
Official photograph, not like standing here, sitting very comfortable, everybody. 그래서 보시는 거야. 나머지 친구들은 수술을 해놔. 나머지는 수술을 해줘. symposium is broadcasted by YouTube. And National Cancer Center also relay this signal to nationwide. So yes, doctors watch. And after the conference, we will move to the dinner together. Yes.
Good afternoon, ladies and gentlemen. My name is Dr. Do-Jung Park, today's MC, and I am a gastric cancer surgeon at Seoul National University Hospital. I would like to extend my sincere gratitude to everyone attending the Seoul International Cancer Symposium 2024 NAMOK-KFCR-KCA joint meeting. This event is also being streamed live on YouTube. Today's symposium will run from 2 p.m. to 6 p.m. and divided into 3 sessions. Now, the symposium will begin. To open the event, we will have an opening address from Professor Kyu-Chang Wang, President of the National Academy of Medicine of Korea. Please welcome him.
Ladies and gentlemen, dear participants, it is my great honor and privilege to welcome you all to the 2024 Seoul International Cancer Symposium, which is a joint annual meeting co-hosted by the National Academy of Medicine of Korea, NAMOK, Korea Cancer Research Foundation, KFCR, and Korean Cancer Association, KCA. The theme of the symposium chosen this year is One World Challenges to Cancer Research and Treatment in the Post-COVID-19 Era. With the 3 sessions, Global Challenges to Cancer Prevention and Transitional Research, Global Challenges to Clinical Cancer Research and Treatment, and Differences in Eastern and Western Views in Euthanasia, Eastern Philosophy. Renowned scholars from France, Japan, and Korea will give their lectures, and in each session, we'll look at the future direction of the cancer research and treatment, which will be followed by an active discussion. In addition to the speakers, discussants, and chairpersons who participate in this symposium, devoting their precious time and efforts, I would like to thank Dr. Yoonok An, the chairman of the Executive Board of Korea Cancer Research Foundation, who has worked hard for the advancement of the cancer research in Korea, as well as Professor Han Kwang-yang, the chairman of the International Cooperation Committee of NAMOK, and the members of the committee for preparing this symposium. I expect that this symposium will be of great help for Korean cancer experts to update the latest trends in cancer research and treatment. It will garner international attention to build up a more close collaboration as well. Please enjoy the updated science, enhance mutual understanding, and refresh friendship through this symposium. Thank you for your attention.
Thank you, President Wang. Next, we will have a welcome address from Professor Yoonok An, Chairman of Korean Foundation for Cancer Research. Please give him a warm round of applause.
Good afternoon, ladies and gentlemen. First of all, thank you very much for coming. On behalf of the Korean Foundation for Cancer Research, KFCR, I would like to warmly welcome you to the Seoul International Cancer Symposium, SICS 2024. Well, the KFCR was founded in 1988 and has hosted annually the SCIS since 1990. As a scientific meeting which contributed activation of cancer research in Korea as well as international collaborations. Since 2018, the SICS has been co-hosted by National Academy of the Medicine of Korea, NAMOK, with KFCR, and Korean Cancer Association, KCA, has joined as a co-host since last year. Professor Han Kwang-yang, now the president of the National Cancer Center of Korea, and as the chairman of the International Cooperation Committee of the NAMOK, and Professor Sun Young La, the chief director of the KCA. I greatly appreciate them for their organization of this symposium. As you can refer to the program of this symposium, the main theme of today's meeting is One World Challenges to Cancer Research and Treatment in the Post-COVID-19 Era. Some central issues and topics of the theme will be presented and discussed, and as well a special session on views of euthanasia will be open also. Today, we are very fortunate to have with us very eminent and leading scholar on the related area of our main theme as speakers from Korea, Japan, Taiwan, and IARC, International Agents for Research on Cancer, WHO. I'd like to express my special appreciation to them for their acceptance of our invitation. I'm so happy to have the honored guest for this meeting. Finally, once again, I'd like to bid a warm-hearted welcome to all to participate in this symposium. And my special thanks go to those who have taken time out of their year-end busy schedule. I wish all of you fully enjoy today's program until the end, and the program a resounding success. Thank for your kind listening. Thank you.
Thank you. Thank you, Professor An. Lastly, we will have a congratulatory address from Professor Sun-Young Ra, Chairman of Korean Cancer Association. Please welcome her with big hands.
Thank you so much. On behalf of Korean Cancer Association, it's really my pleasure to co-host this important symposium. Actually, I remember it's more than 3 years. And as you know, the cancer is a very complex disease with multiple scopes. So not just diagnosis, but have advanced cases and the hospice care, all those are very important. And we need a multidisciplinary approach to treat those cancer patients. So this type of multiple co-hosting symposium is really important. And again, I really appreciate all those speakers and the participants, not just offline, but also we have many online people. So hope to join this meeting. And it's not just academic interaction. I hope it's becoming a real collaboration to change our practice and the influence of our cancer patients' treatment. And as a chairman of Korean Cancer Association, we are having many international symposium. One of them was just finished last year with AACR-KCA Joint Symposium. Next year, we will have Asian Oncology Society meeting, which is one of the most important Asian cancer symposium in July. So I hope to see you, many of them, in those meetings again. So again, enjoy this important meeting and I expect more interactive discussion. Thank you so much.
Thank you. Thank you, Professor La. Before the first session, we will have a group of photography time. So. Now, let's begin first session 1, titled Global Challenges to Cancer Prevention and Translational Research. This session will be chaired by Professor Sun-Young Ra.
Thank you so much. It's my honor to chair the session 1, which is Global Challenges to Cancer Prevention and Translational Research. And I should inform you that 2 speakers cannot be here, so please understand about the situation. So we will have that video, and then we have a panel discussion. So the first speaker is Dr. Jin-Young Park from IARC, International Agency for Research on Cancer, France. So because of the time difference, and also she could not be here, she will give the talk, recent progress in gastric cancer prevention. So we will have the video, right? Yes, please.
Hello everyone, my name is Jin-Young Park, and I'm a scientist leading gastric cancer prevention team at IARC. Today I'm going to talk about developing guidance on the implementation of population-based H. pylori screen and treat strategies for gastric cancer prevention, largely based on our 10 years of experience since the last IARC working group report. I have no conflicts of interest to declare. Gastric cancer remains an enormous public health problem globally. It is the 5th most common cause of cancer and cancer death worldwide. And as you can see from these pie charts, that the majority of the new gastric cancer cases and cancer death come from Asia, mostly China. This graph shows incidence on the x-axis and mortality on the y-axis, and each dot represents a country in different continents. As you can see, that gastric cancer incidence is closely aligned with its mortality, indicating absence of preventive measures in most of the countries. The exception for this is Korea and Japan, as you can see in this red circle, where nationally organized gastric cancer screening programs are in place. This graph shows top 15 countries for gastric cancer incidence and mortality. Mongolia tops in terms of incidence and mortality, followed by Japan and Korea, but with much lower mortality than other countries. Despite decreasing incidence trends observed in many countries, gastric cancer will remain an important public health problem globally. IARC's GlobalCan estimates suggest that in 2050, due to demographic changes with aging and growth of the population, we will foresee double the number of new gastric cancer cases. And the figures are similar for the gastric cancer death. More importantly, we will have, first of all, continued high burden in high and very high Human Development Index countries, especially in Asia, as you can see here. However, the biggest increase in gastric cancer burden is foreseen in countries currently assigned to a low and medium Human Development Index. This means that we can expect a new wave of new gastric cancer cases in lower risk settings, and that requires our attention because we need more affordable preventive strategies. Similarly, by WHO region, we will have continued high burden in Asia and rapidly increasing burden in other regions, such as Americas and Africa, due to demographic changes. Is gastric cancer only the problem of elderlies? It is not as is often thought. The incidence rates skyrockets after age 40 years in intermediate or high-risk areas, indicating that it affects actually economically active population, leading to premature death in countries without active control programs. More importantly, more than 50% of gastric cancer deaths in the world occur in younger than 70 years old. Although incidence rates increase with age, the number of gastric cancer cases is higher in younger ages because of the structure of the population. This is important, especially in Asia, due to aging population. The most significant risk factor of gastric cancer is chronic infection with H. pylori, which infects more than half of the world population. And H. pylori infection is responsible for 70–80% of non-cardiac and 62% of cardiac gastric cancer cases in Asia. And gastric cancer can be prevented by H. pylori eradication. H. pylori eradication has shown a reduced gastric cancer incidence and mortality in randomized control trials, mostly conducted in Asia. The analysis also showed that over $8.7 million would be gained if H. pylori test and treat programs were implemented globally. This recent publication, which shows long-term follow-up results of H. pylori eradication in China, also demonstrated 43% of reduced gastric cancer incidence and even larger reduction in participants without precancerous lesions at baseline. In 2013, IR convened a working group to discuss Helicobacter pylori eradication as a strategy for preventing gastric cancer. The IARC working group recommended that gastric cancer is an important disease on which global action is required, and it will remain important for the foreseeable future unless effective control measures are implemented. And therefore, the country should explore the possibility of introducing population-based H. pylori screen and treat programs, however, in conjunction with a scientifically valid assessment of a program processes, feasibility, effectiveness, and possible adverse consequences. One of the important ongoing initiatives on H. pylori eradication is the HELPA study. HELPA is a clinical trial that aims to evaluate the effect of H. pylori eradication on gastric cancer incidence within the National Gastric Cancer Screening Program in Korea, which invites everyone aged 40 onwards to biannual endoscopic examinations. The National Cancer Center launched the study in 2014 in collaboration with IR, and almost 12,000 participants were enrolled, and 5,269 were randomized into bismuth quadruple therapy or placebo from 12 study centers across the country. The biannual endoscopic follow-up is ongoing, and we are planning interim analysis within the next years. Earlier in March this year, we celebrated 10 years of the HELPA study by having a major meeting with all the HELPA study investigators. Another study that I would like to introduce is called GSTAR, which is a population-based study that has been conducted by the University of Latvia in collaboration with IARC. The GSTAR study aims to determine whether H. pylori eradication combined with pepsinogen testing will reduce gastric cancer mortality among 40 to 64-year-old individuals. Since this study is important for the European initiatives that I'm going to present in the next slides, I'll briefly show you the design. Participants aged 40 to 64 are randomized into the intervention or control group. Intervention group is tested for H. pylori and pepsinogen levels, and H. pylori positives are treated, and those who have decreased pepsinogen levels undergo upper endoscopy. In the control group, participants get routine medical care and follow-up. The study is ongoing in Latvia, and then we recruited more than 10,000 participants already 3 years ago. The pilot GSTAR study was initiated in 2013 and was completed in 2015 prior to launch the major study. The pilot study was conducted in 4 study centers in Latvia that you can see in blue square. And in the pilot study, H. pylori prevalence was 68%. Eradication success was high, and altogether more than 1,000 endoscopies with full histological assessments were made. After successful completion of the pilot study, the main study has been being carried out in 7 additional centers, indicated here in red squares, totaling over 11,000 participants enrolled so far. The GSTAR study is important as it is the only large-scale gastric cancer prevention study in Europe, and it has been very instrumental for Europe's prevention efforts for gastric cancer that I'm going to show in the next slides. The European Commission announced Europe's beating cancer plan in 2021. It has 4 pillars: prevention, early detection, diagnosis and treatment, and quality of life of cancer patients and survivors. The beating cancer plan addresses gastric cancer under the section preventing cancer caused by infections, saying that the Commission will help ensure access to treatment to prevent gastric cancers associated with H. pylori infections. Gastric cancer was also mentioned for the section of improving early detection of cancer, saying that extending targeted cancer screening to include additional cancer sites such as gastric cancer will be considered. Subsequently, SAPIA, which is part of the European Commission's scientific advice mechanism, recommended that population-based screen and treat programs for Helicobacter pylori are recommended in regions with intermediate to high gastric cancer incidence. In Europe, there are three major initiatives for gastric cancer prevention, namely EuroHelican, TOGAS, and ECIGC, for which IARC plays a leading role. First of all, EuroHelican assesses the implementation aspects of population-based H. pylori screen and treat programs in Europe. As part of the EuroHelican project, IARC has convened a working group of experts to provide practical guidance on the implementation of the strategy that I'm going to talk a bit more in detail in the next slides. TOGAS, the largest project with 21 consortium members, will complement the EuroHelican project by providing, for the first time, essential information on both primary and secondary preventive strategies for gastric cancer prevention. This knowledge and experience will be integrated then afterwards into the new European Commission initiative on gastric cancer, which aims to develop the European guidelines and quality assurance schemes for gastric cancer prevention and care across Europe. The working group meeting and the report that IARC has been planning is an update of the previously mentioned 2013 working group meeting and the report, and it aims to provide practical guidance on the implementation of population-based H. pylori screen and treat strategies for gastric cancer prevention that is globally applicable. The meeting will be held next February in our new headquarters in Lyon with 32 experts from 21 countries. The core working group members include Drs. Ichia Lee, Pomo Eadi, Constanza Camargo, Iris Lansdorff-Vogeler, and Boyan Tepesh, who have been tirelessly working with us in this major effort for more than a year by now. Very briefly about the preliminary outline of the report. We tried to cover practical aspects and considerations that need to be made when implementing the strategies for gastric cancer prevention. More closely for Chapter 3, we also will cover the various areas for the examples of gastric cancer prevention efforts, and those efforts will be described by WHO regions. We are currently at the final stage of peer review of the chapters for the report before sending them for professional editing. We expect those chapters will be ready for the February meeting, and the final publication of the report is expected in April. The IARC Working Group report will be published in a dedicated IARC and WHO publication platform. We also expect to publish at least 2 manuscripts related to the meeting and the report. These extensive experiences in global gastric cancer prevention will facilitate the development of the European guidelines and quality assurance schemes that's existing already for other cancer sites for gastric cancer prevention, screening, and care, and IARC is going to take a lead on that work. The guideline and quality assurance scheme for gastric cancer will focus firstly on the H. pylori screen and treat programs as primary prevention strategy, and will be later followed by screening and diagnosis and treatment in the second set of the guidelines. In the field of gastric cancer prevention, we have currently very limited data on the feasibility, acceptability, and long-term effects of different prevention strategies worldwide. And that contributes to the disconnect between the available evidence-based interventions and their implementation in prevention programs. So we need greater efforts to collect more information on how to make the program work in real-world settings. The new evidence generated within the European initiatives and also the recommendations expected from the IARC Working Group meeting will then be integrated into the guidance instruments, and especially when developing the new European guidelines for gastric cancer prevention, screening, and care. Thank you very much for your kind attention. And I would like to acknowledge Victoria and Karima for their great contributions to the European initiatives.
Thank you so much. It's a great talk, but again, as we could not have Dr. Park, we will have a Q&A during the panel discussion. So please think about the discussions or the comments for that. Okay, so because as you heard, she is not only leading the France, the Europe area, but also lead work in the WHO. She knows a lot about the whole global situation, which is different by the region. So I think if we have her, it'll be great. But at this moment, we will discuss within ourselves. So we will move to the next speaker, Dr. Ji-yeon Lee. She is the medical oncologist of Samsung Medical Center. She's been working a lot in the clinical trials and also the translation research of gastric cancer, and especially she did more of various precision medicine related research. So she will give us the talk, clinical research through precision medicine in oncology. So please start the video. Thank you.
Hello, everyone. My name is Ji-yeon Lee. I work at Samsung Medical Center. I'm very pleased to be here to present my work. And my apologies for not being able to join in person because I have a conflicting schedule, but I'll do my best to present my work. My title of the talk is Clinical Research Through Precision Medicine in Oncology. And as a medical oncologist, I would like to share what we can do to treat our patients better through research in clinical practice. So what does cancer mean to us? It means that you get a sudden onset symptoms, and this patient was a 36-year-old female, a mother of a 5-year-old boy, and the patient was diagnosed with gastric cancer peritoneal seeding. What cancer means to our patients is that after saying hello, actually bye to her son in the morning, he's going to the kindergarten, and the patient sits down in her garden and say, will I be able to see the roses next year again? So this is really a devastating disease, destroying the family happiness. And we have, although the survival and treatment outcome has improved a lot in gastric cancer, we have lots more to do. As you can see here, the incidence of cancer is increasing, and it will be increasing over the next decades because, as you all know, we are in the aging peak, especially in South Korea. So we are in a busy clinic, and I sit down for a while and think about what we can contribute to cure cancer as a clinician. So if you could see how much we deliver in our daily practice, is that we deliver about 1,000 chemotherapy daily, including oral chemotherapy. 20% of chemotherapy is immunotherapy, and about 20% of our patients are enrolled on the clinical trials. So that's a lot of database and a lot to learn from. We also test every metastatic cancer patients with NGS. In our practice, we use tissue and blood, basically two tests are reimbursed, 50 to 80% in Korea. So in our clinic, under diaphragm, about 300 to 400 patients undergo NGS tests per month. So that's another important database that we can accumulate. Also, the test platforms. We have variable platforms available for clinicians, including Illumina TrueSight 500. We also adopted OCA Plus from Thermo Fisher, TrueSight 500 Liquid. We have Garden 360, Garden Infinity, and Reveal test for MRD testing. So from diagnosis to death, we have longitudinal data available in about 95% of the patients. I think that's what makes peculiar for Korean clinical database. But the real world data, we only use about 1%, probably less than 1% of the database that we generate for publication and research. So I think we can do better, and we always strive to do better using this database to do better next time for our patients. Let me share my patients' cases. So this patient was a gastric cancer patient who had gastrectomy and then recurred after standard adjuvant chemotherapy, and the patient recurred to ascites and multiple lymph nodes. The patient received standard chemotherapy with Ramtax and irinotecan, and her NGS gave a very, very rare fusion called MET fusion. The partner was LRRD fusion, and we enrolled this patient onto MET inhibitor. And what we have found is a almost complete remission to MET inhibitor. This dated is back in 4 years ago, and this patient was on MET inhibitor for 3 years, this is another patient with MET amplification gastric cancer patients. This patient was a 35-year-old man, no reason to get gastric cancer. He had excruciating pain, was diagnosed of multiple metastases from gastric cancer. The patient had MET amplification, so we enrolled this patient onto a MET inhibitor trial. He had dramatic response to MET inhibitor after like 2 cycles. He didn't need any painkillers or anything. But unfortunately, 3 months later, the patient had his disease back. As you can see, some of the lesions are overlapping, but some of the lesions, like spine metastasis, those are the newly developed lesions. So we had to take him off, and after disease progression, the patient rapidly deteriorated in performance. So we had to let him go. But what we had at that time is a platform biomarker study. So we collected plasma at baseline, on treatment, and at progression. And the reason why we did this was we wanted to understand the biology in our patients so we can do better next time. And what we have discovered is that although MET amplification is here, MET amplification itself was decreasing as the patient was getting MET inhibitor, but unfortunately, the patient had activating MET mutations emerging even at the time he was doing well, and when the PET-CT was even, almost complete remission. And this started to come up, and this is when the disease became chaotic. So what we learned from this patient is that although we couldn't save this patient, we learned that, collecting the samples and doing retrospective analysis does mean a lot, and it will help to guide us in better design for future clinical trials. This is another patient with melanoma. The patient was with me for about 10 years with metastatic disease, with nivolumab, dacarbazine, ATR inhibitors, every trial that was out there, and there was Keytruda. And at this time, the patient wanted to stop chemotherapy. But if you could see here, in 2017, we had only 50 gene in this panel. 2018, we had 150 gene panel, but we didn't see any aberrations then with that small panel. But in 2019, I offered her to receive Garden 360 because we didn't have anywhere to do a safe biopsy from. And the cell-free DNA results gave BRAF deletion. But at this time, we didn't know what BRAF deletion meant, although it looked like an activating aberration. We talked to Genentech medical scientists if this is a real activating mutation, targetable mutation, and we got the answer back in 2 weeks that this patient would be eligible for their trial, which is MEK plus BRAF inhibitor. And fortunately, all these black dots are metastatic disease, and this patient was on the MEK and BRAF inhibitor for a while, like 2 years, with no symptoms. and progressed, and she is still on another trial after failing to MEK and RAF inhibitor. So definitely NGS test, whether it is cell-free, whether it's small or big, it is really helping our patients in real world. So I just wanted to mention how we started this 10 years ago. It's now 12 years ago when I proposed this to industry. What we had was genomic screening program. What we didn't have was the right drug lined up for genomic testing. So if you don't have right drugs in right timing and right place, genomic testing doesn't really mean anything to our patients in terms of clinical benefit. So AstraZeneca was the third company to ask, and Dr. Susan Galbraith, she said, I think this might work, and we will give our whole pipeline to you as to test if it works in gastric cancer space. And what we have showed for the first time is that biomarker-driven treatment in second line actually does improve overall survival rather than just conventional chemotherapy, and it was published in Cancer Discovery. Now I want to switch gears and talk a little bit about implementing high-end biotechnology and what happens in our clinic. So I was a younger oncologist. 2013, I met this small biotech company called Garden 12 years ago. And he said, I could test NGS from cell blood. And at that time, in 2013, like almost 90% of us didn't believe that tissue NGS would actually benefit our patients in the clinic. And now he's bringing blood NGS test, which, sounded like a, SF science fiction at that time. But I said, okay, I'll give it a try. And I did an investigator-initiated trial with him on 100 patients. I think this patient was the 30th patient who got cell-free DNA tested. This patient was melanoma, and this patient had BRAF V600E. What was interesting was this patient had failed to about 3 to 4 standard regimens, and the patient was asked for hospice care from another hospital. And before he went to hospice, he wanted to get more treatment from another hospital, so he was referred to my clinic. And we have a very busy clinic, so you don't get to check all the results real time. And at that time, the CEO of Garden emailed me in 2013 one day and say, it's October 2013, and say, did you see that patient has BRAF V600E mutation? So, okay, I'll check. And at that time, we were testing BRAF as with Sanger sequencing in FFPE. And our results and another big hospital's results were BRAF wild type or insufficient amount of tissue to be tested for BRAF. So I had to do liver biopsy again and recheck if this is true. And this patient did have V600E mutation. So what happened was this patient received bemrafenib as part of a clinical trial at the time. I think it was an EAP. And he had good 10 years of symptomless period of time. And this patient really did well on BRAF V600E inhibitor. So every day we gain knowledge from our patients, even just one clinician like me who sees about 80 to 90 patients per clinic. And I learn every day 100 different combinations of genome plus treatment response from each patient. So each patient will have MET plus FGFR2 amplification, MET plus KRAS mutation, MET plus TMB high, and differential response to MET inhibitor. So which means that we know a lot from our patients, but we don't have this database in a way that it can be reused for other patients. So I think we only report less than 1% of what we know. We have accumulated about 20,000 NGS plus clinical information. It's a real-world database. And also we go deep sequencing in a clinical trial, genome integrated trials. And we have collected 2,000 whole exome sequencing, RNA sequencing, and single-cell sequencing in especially immunotherapy treated patients, and published from Nature Medicine to Annals of Oncology to Cancer Discovery. And we have collected about 4,000 deep sequencing from gastric to colon to ECC to melanoma to bladder to biliary tract cancer. So we are not only doing genomics, but also having layers of transcriptomics, single cell transcriptomics, and proteomics. And now we are trying to set up single cell proteomics as well. And this is, some of the example of publications that we have published out of this database. So NGS is going to increase in rapidly. It's going to be part of our clinical practice, and we are just talking about the stage 4 patients regarding therapy selection testing. But now it's moving on to minimal residual testing, like MRD testing to monitor recurrence, and also prognostics, and also hereditary cancer testing and cancer screening program. So I think all of these spaces will be here within a decade, given the rapid advance in NGS space, and especially AI algorithms convergence. So what we have done at SMC is to get ready for this era. This is the single report on single patient that we see every day in our practice. So this is NGS report from a single patient. So you can think of so many variables behind this, demographic data, age data, disease type, the types of chemotherapy that you're receiving. So 100 variables at least behind this NGS scene. And the NGS usually has about 500 genes and probably 20,000 variants behind this. So if you think about that, it is very hard to have an algorithm found out by a manual analysis. So we sat down and we have generated a database to visualize and see what we are seeing in our patients and where the unmet need is, so we can get clinical trials into an unmet need population, number one, and we can help or provide advice to companies who has a machinery to develop good drugs, and tell them where the unmet need is and where it can be done right. So this is what we are doing right now. And step 2 is to have, since we have this all sorted out, we are trying to make this as an explainable AI for clinicians to assist our decision in everyday practice. And this is all part of academia, so it's happening in Samsung Medical Center. So the question would be, I don't know if you have used ChatGPT or OpenAI for getting information, but I think once you use it, it's hard not to use it. And the question that we confront every day in our clinic is that if the patient has KRAS G12D plus FGFR1 amplification versus just KRAS G12D alone, will the patient respond to beva-volfiri the same way? Will the response be deeper, different? Will you have mixed response? That is very likely, because you're going to have a lot of heterogeneous clone with KRAS amplification plus, KRAS mutation plus FGFR1 amplification, because it usually happens in different cells. We have published that a few years ago. So we are trying to make this as an AI for clinicians, so we can perform better and give optimized treatment for our patients in the future. So immunotherapy, what does it mean? It means there has been a paradigm shift. I know there's a controversy between regarding TMB high, whether it is real or not, but I know in the clinic that it is real. This is a 48-year-old small bowel cancer with peritoneal bleeding, very painful. He was admitted via ER. And when I looked at his NGS, the patient had TMB high. So I gave him 6 cycles of pembrolizumab. And this is what happened. It was like 90% gone, disappeared. And it has been disappeared this way for 4 years. So it is real. The patient did not have MSI high. It was only TMB high. But if you look at the mutation number, it was pretty high too. So if you have a real high tumor TMB high value, then you might benefit from pembrolizumab or nivolumab alone. This is the mass that you see here. It was disappeared like this after 6 cycles. We had to take him off because of financial toxicity, but the patient is now doing fine. So 6 years ago, we have published who's responding to pembrolizumab in gastric cancer. We found that MSI high and EBV positive patients were the ones who are responding. And now we are going back to the tumor blocks and trying to map why some EBV positive patients responded and some did not using spatial transcriptome. So if you look at this patient also achieved complete remission after 35 cycles of pembrolizumab. The patient is still in complete remission. So basically the patient is cured because it's been 5 years now. But if you go back and look at the baseline biopsy, the patient had a lot of CD8 positive T cells here. So all we had to do was just passively block the PD-1, PD-L1 axis and let CD8 positive T cells kill the tumor cells. And also we are going deeply in some of the very hard to treat gastric cancer like MSS, without good tumor environment with single cell and spatial transcriptomics. What was scary was if you do chemotherapy, you get a lot of tumor microenvironment change, some in a good way, some patients in bad way. And after you give chemo, you get different types of response. So the reason why we are doing this is that if you do a appropriate mapping of immune system in the tumor while you're treating patients as part of clinical research, you'll be able to find new targets and how to, new clinical trial strategy to optimize treatment outcome. So this is the platform. We established this platform while we are doing victory trials. It's been 10 years. We do biopsy, and then try to incorporate new technologies when it becomes available. So every day we gain knowledge from our patients. Sadly, we are reporting and sharing only 1% of what we already know. I think our clinicians' job is to make this available to drug developers, to basic researchers, what is really happening in our patients in order to rapidly enhance this clinical field to achieve better treatment outcome. So my idea is to make every data usable and analyzable for future medicine. We collect samples. We now have streamlined the data generation hub, and we make each cohort. And when industry partners or academic partner comes in, we collaborate. So I would like to end with Mr. Jensen Huang's comment. What he said was, I was looking at this YouTube and suddenly this popped out, and it was very stimulating for me. He said, he's the NVIDIA CEO, of course, and he said, if I were to do this all over again, I would spend my technology to turn life science into life engineering, because human biology is the most complicated process. So this is where clinicians' role is, to make data available so AI could pick up, so AI can assist us when we see our patients. Thank you very much.
Thank you so much. So yeah, you heard that the first talk is more of early cancer, so screening and prevention, and the second talk is more of advanced cases. Actually, I see most of these metastatic cases every day, so I really enjoy the talk. And again, we cannot have those two speakers, but we have a panelist, Dr. Yeol Kim from National Cancer Center, Department of Cancer Screening and Examination. Yes, so he's over there, and we will have a panel discussion. And anyone who have questions or comments, you can start. So even though two presenters are there, I think we will have a good discussion. So before starting the Q&A, I will ask Dr. Kim about his thoughts and the comments on these topics. So Dr. Kim, please.
Okay, thank you. Can I talk at here? Okay, I'm at here, not on the line, online. Okay, I'm Yeol Kim from Korean National Cancer Center. Thank you very much for inviting me to this meaningful academic meeting today and giving me the opportunity to discuss on cancer prevention and early diagnosis and personalized approach to cancer treatment. Precision medicine is now an international trend and research directions in cancer field also. For cancer prevention, the results of our study presented today by Jin-Young Park from IRC proved the effectiveness of the H. pylori eradication's treatment in preventing stomach cancer. The important meaningful studies suggest the important methods to prevent stomach cancer and reduce deaths caused by stomach cancer in the future worldwide. The results of this H. pylori eradication prevention for stomach cancer study achievement can be supported by our long-term research supporting funding from Korean National Cancer Center and collaboration with the major cancer hospitals in Korea and the international cooperation with the International Agency of Research on Cancer, IRC. It's a very memorable study achievement, I think. Next lectures from Professor Jian Lee, lectures on precision medicine in cancer give us very well summarized information on the development in this field so far. In order to develop the customized cancer treatment that targets individual genetic mutations with the precision medicine targeting immunotherapies and for cancers, I think there are some problems to treat Asian population cancer patients treatment with the immunocancer drugs from that developed from Western countries. As I know, the common cancers developed in Asian populations and Western countries' cancers are quite different. Also, cancer types are different, and the genetic proteomic mutation could be different from Western countries and developed in Asian countries, also in Korean populations. So we need to new researches on this field. We need to collect genetic data from Asian cancer patients and conduct research for the development of new treatment for our patients. I think the most important infrastructure for these new challenges is we need big data that combines genetic information from our patients and also we connect with the patient's clinic informations. And we need to create a research cooperation environment that links from material development at bench to clinic applications and technology development. I think today's symposium is an opportunity to make a new paradigm of collaboration with the various experts and companies in our countries and international cooperation to develop research leading to personalized cancer treatment based on cancer big data of Asian cancer patients. Fortunately, we already building the cancer big data, collaborate with the Korean National Cancer Center, leading by our president, the new president, Yang. I think collaboration with the multidisciplinary experts and make research environment from bench to clinic combination with the AI technology would be key components to develop a new stage of cancer precision treatment in the future. Thank you again for giving me the opportunity to express my opinions in the valuable meeting. Thank you.
Thank you so much for the comprehensive thoughts. So now it's open for the questions and comments. Okay, that's please, Dr. Yun.
Well, can I have the question to the Jinyoung Park? Can I have the question
She
to,
is not here
to her?
because
Yes,
because of the time difference. She could not join. But I think Dr. Kim can answer. You can because I have several questions too. So please, please have a question.
Well, as further gastric prevention, to understand the risk factor for gastric cancer shall be important, isn't it?
Yeah, yes.
But Dr. Park mentioned only one risk factor, H. pylori infection. But as far as I know, another risk factor is the high salt diet. So what I want to know from the Dr. Park is, she can tell us the interactive effect or coactive effect between two risk factors for the gastric cancer.
Yeah. I'll try to explain. The research was conducted 10 years ago, collaborate the KNCC with the IRC to see the H. pylori attributable fractions to develop the gastric cancers. Adjusting by sex, age, or that like diet problem causes by RCT, randomized controlled trial. So, Professor, you know, gastric cancer incidences are quite rapidly decreasing in our society because of our diet have been changed. Our population diet has been changed. We recently take on fresh diet, low salt diet, but increase the lipid diets. But as that kind of the healthy behavioral change may decrease the stomach cancer, but stomach cancer is still high incidence in Korean populations and some part of international countries. So that research focus on how H. pylori treatment eradication how much can prevent the stomach cancer development. Then the research outcomes are not proven yet, but the interim results shows very high proportion of the attributable factor proportions to develop the stomach cancer by H. pylori eradications. It's we think a new paradigm, new findings to prevent the stomach cancers, as I know.
My point is the interactive effect of two factors, not independent effect. She already presented the independent effect. But what I want to know with the inactive or coactive effect. Yes. So, for example, in the same level of the H. pylori infection, the risk is different between the high salt diet or low salt diet. That means that the inactive effect between two factors. Yeah.
I'm not sure the research team how much adjusting the factors with the H. pylori eradication and the diet behaviors. But as I know, they collect the data of the dietary information and make a statistically adjusting. But I'm not sure. Sorry.
Yeah, so that's very important question. In part, that is not easy to collect as an objective parameter, but I understand they are collecting those environmental factors and diet habits. So I will ask Dr. Park whether collecting questions from this session. So I hope we can get the answers from her later. Okay, so yes, Dr. Park.
Dr. Park from Seoul National University. I really enjoyed this session, and I have one question to Professor Yeol Kim, because as I know, he is very expert in the prevention of lung cancer and the trend of the prevention and some personalized therapy in lung cancer society. So, could you give us a comment of some different point of access from the prevention of each cancers, or some personalized some trends of the treatment clinical trial also?
Okay, thank you for the very important and difficult questions. Yes, I'm one of the experts of the smoking cessation in the lung cancer field, and also I'm in charge person to conducting the lung cancer screening in our countries to early detections. You know, lung cancer, to develop lung cancer, smoking is a very important major risk factors. But and H. pylori or salt intake is a very important causes of stomach cancer. But some cancers we do not the dominant risk factors for the pancreatic cancer or renal cancer. We don't know, not yet. But that some cancers, the dominant risk cancers could be controlled, and that means that the parts of prevention, smoking cessation, and decreased salt intake, decreased alcohol intake, increased exercise, can the modifiable behavioral factor can prevent cancers generally. But individualized approach to make individualized approach to prevent cancer prevention, we need to know who the person's behaviors and genetic factors interactive with the factors and their intrinsic risks of the developed cancers. We need to research with the big data. It already conducted internationally, USA, UK, and we need to follow up the research to cancer prevention and also the field for the cancer treatment also, I think.
Right. Following that, I remember last year AACR, they presented the ctDNA of thousands of thousands of volunteers, and it's a kind of a registry, and following those people who are going to get a cancer like that. So when I see those data, I think that is a kind of a starting point of understanding precision characteristics of those people who have a high risk of cancer development. But for the screening and the prevention, I think we think about the cost effectiveness. So I feel that's very good study, but it's not easy to do in Korea also. So based on each country and each economic status or the incidence of the disease, we can think about the different approach. So starting from the not with the whole healthy people, the clue starting from the patients. So I think the second session of that advanced cases with a genomic study might have one understanding who are the more risk factors to screen. So one of the Dr. Park mentioned that targeted cancer screening. So one is the family risk or the high risk incidence, but also there is a potential with high cancer risk factors based on the germline testing or the genetic testing. I think those are the good start for the precision prevention or the screening. Again, we need a big data. The problem is how we can get the data is a big issue. We need a big support and the grant for those studies. So always after the talk, we should think about the how and in the real practice. So following that, I have also the questions to Dr. Park and Dr. Kim. So one of the easiest way to screen or the prevention is hereditary cancer. So do you have any screening program for the hereditary cancer in the National Cancer Screening Program of NCC? And please explain a bit about that.
That kind a very important and difficult question. Thank you. The Jin-Young Park team's studies to prevent stomach cancer by eradication of the H. pylori is a starting target to the hereditary cancer. It's a means of stomach cancer families. Is the first target to see the prevention effect. It's the first step, I think. We need to research more about that kind of research to target the family members of other cancers, how we can prevent or early detect the cancers. We need to research, and the clinical application is later, I think.
And regarding the second talk, I'm also in the same field in the medical oncology. So if you have any questions or comments on those things, I can answer for that. So for the metastatic setting, the precision medicine using NGS of tissue or the blood are very critical to determine the treatment, and that makes the outcome very different. So as you heard from Dr. Lee's talk, now we have more and more potential to use those technology in the clinical practice. And we have more and more database already. And as Dr. Kim mentioned, that we have some differences from other countries by region. So our data collecting more and more from the clinic will make a difference in the treatment of our patients. And I think the third session is about that ethnic differences or the Asian Western differences. So hope to discuss more. So yeah, without two speakers, we have a discussion already. So because of the time, we will finish this session. And thank you so much for all those participation. Thank you.
Thank you. The second session, Global Challenges to Clinical Cancer Research and Treatment, will be moderated by Professor Han Kwang-yang from National Cancer Center, Seoul National University, and Professor Kyung-Ha Park from Korea University. Please.
Welcome to session 2 or session 2, Global Challenges to Clinical Cancer Research and Treatment. Welcome to session 2, Global Challenges to Clinical Cancer Research and Treatment. This session will be chaired with Dr. Kyung-Ha Park from Korea University, and Dr. Park will introduce the first speaker, and I will introduce the second speaker. Please. Yes.
Good afternoon, everyone. This is my great pleasure to introduce Professor Kyung-Sang Yu from Seoul National University. Professor Yu graduated from Seoul National University in 1996 and then received a PhD from the same university. And also he received MBA in International Business from Yonsei Graduate School of Business in 2003. After he finished his training as an internship and clinical pharmacology at the Seoul National University and finished the military service. He started his career at the Seoul National University Department of Clinical Pharmacology and Therapeutics as a professor in 2004. And then in 2019 and 20, he visited as a visiting research scholar to Cedars-Sinai Medical Center, LA, California. From 2021, he's been chairing the Department of Clinical Pharmacology and Therapeutics at the Seoul National University College of Medicine and director, and also the vice director of the Clinical Trials Center at the Seoul National University Hospital. So topic of his talk is decentralized clinical trial, opportunities and challenges in Asia. Professor Yu, please.
Thank you for your kind introduction, and it's my honor to speak in this wonderful symposium. So today I will be talking about decentralized clinical trials. So decentralized clinical trials, maybe you have heard, because recently it has become quite a buzzword especially in the clinical trial regulatory arena. Especially after the pandemic. It's defined as a clinical trial where some or all of the trial-related activities occur at locations other than traditional clinical trial sites. So as you see in the figure below, left panel, in a traditional clinical trial, all the important trial activities are done at the hospital, trial site. And the patient has to visit the trial site for a follow-up or drug administration, dispensing, and other clinical endpoint checkups. But as you can see on the right side, in a DCT concept, one or many of the clinical trial activities can be done at the patient's home or near the patient's home, that is remotely from the clinical trial site. So this has two implementations. One is about physical location. So as you can see here on the y-axis, traditional trials were conducted in the trial site facility, but in a DCT, it can be conducted remotely. For example, near the patient's home or at the workplace of the trial participant. And on the x-axis depicts how the data is captured. So for traditional trials, data had to be captured on site. That is, the patient had to visit the trial site to make measurements, get imaging biomarkers, and do assessments. But in DCT, when we are using DCT elements, data capture can be done. Here, the intermediary you can consider as a clinical research coordinator, and this can be done without the help of a clinical research coordinator or the investigator. So, for example, wearable devices or mobile phones or other kind of remote digital technology can enable us to capture trial data without the help of any personnel. So actually, DCT, we use it as a kind of convenient term for this type of trial. But actually, I would like to explain it as clinical trials using decentralized elements. Because if you say DCT, it may convey the notion that it's a new kind of clinical trial, but actually it's not. It's the clinical trial is the same. The characteristics of a clinical trial is the same, but in the methodology, we are just using some decentralized elements, such as web-based recruitment, teleconsent, that's remote consent, and direct patient shipping, digital data collection, electronic data capture, remote patient monitoring, remote trial monitoring, local labs. near the patient's home, or home visits, or telehealth. So you can see here that we have been using some of these elements for a long time, such as online patient recruitment, or digital data collection, or using mobile phones or smartwatches and so on. So this is not new. The reason that it has become a just very popular keyword is during the pandemic, as you all know. And there have been many terms such as virtual trials, digital trials, remote trials, direct-to-patient trials, but the common term has been made a consensus into decentralized clinical trials. And I would give a caution of using virtual trials because it can be confused with a clinical trial which does not involve an actual patient. For example, a digital twin. So we are not talking about a digital twin or a simulated patient here. We are talking about an actual patient in an actual clinical trial, but using some decentralized or remote elements in conduction of the clinical trial. So decentralized clinical trial is not always have to be remote or digital, but many times it's remote or digital. Even if it's not digital, we can use some elements such as remote patient sample collection or direct shipping of investigational products or clinical trial material to the patient. We can ship some supplies to the patient's home, or we can collect patient samples while the patient is at home without digital tools. Of course, it's more convenient to use digital tools, but the concept does not necessarily need to have digital tools. And it's often remote or digital, and it needs to be patient-centric. It means that, I'll talk about patient-centric in the next slides. So the global trend is that in the recent few years, many of the advanced regulatory blocks have been issuing guidances, US FDA, EMA, the ICH Global Harmonization, also Taiwan. China has released some part of DCT guidance for rare disease, and but Japan and Korea are working on it because they are somewhat different in the legislation and regulations. In the North America, US, many of the population is far from the trial site or the kind of a major hospital setting. But even in Korea, although we are very densely populated, in this work, we analyzed the social network analysis of clinical trial sites in Korea. It's majority of the trial sites are in Seoul, Gyeonggi-do, a little bit in Busan or Daegu, and the majority is in Seoul metropolitan area, which means that although many of the population is in the Seoul metropolitan area, many of the people living in the rural areas or less densely populated areas, such as Gangwon-do or Jeju-do or other areas, they have less access to clinical trials. So I'll give you some examples in oncology. Actually, the DCT is more feasible. Remote or decentralized areas, you can imagine, is much more feasible in other areas because of safety issues, more chronic disease, or with these drugs that are the safety profile which are more established, it's more safe to conduct decentralized trials. So they were more active in dermatology, psychiatry, and cardiology. Cardiology, they have been using some wearable patches to monitor atrial fibrillation and other events. So that's kind of a very specific area. So why not in oncology trials? So endpoints often involve advanced imaging, blood tests, and biopsies. So the patient has to visit the trial site. And also treatment, many treatments are still toxic or have a narrow therapeutic range and must be done within the hospital, many times intravenous infusion. And the patients may require highly concentrated care. But there are some examples in oncology. This was conducted during the pandemic and published right after. This was a trial in the US, Western US. But the alectinib was actually approved at that time. And it was an oral therapy for ALK fusion positive non-small cell lung cancer. And that's why this drug could be shipped to the patient or to the local clinic. So here you can see that they had, since this is a rare variant type, it's not easy to recruit from a single center. So this foundation had NGS test results from a wide population. And when they found ALK positive patients eligible for enrollment in this study, they contacted the local oncologist. And with the help of the coordinator, oncologist contacted the patient, and the trial was conducted with the study investigator being at a remote site. And with this kind of scheme, they could recruit patients from a very wide regional area, which would not have been possible with a single center with the patient population just nearby because of this rare nature of this variant gene. So this was the study summary involving the NGS results, local oncologist, and there was a mobile nurse which would visit the patient's home, and a remote platform from Science 37 company. And the local oncologist will receive all clinical relevant updates, and the radiology studies were conducted at a local radiology facility. So if we use decentralized elements in oncology, the advantages would be trial accessible to patients regardless of location, faster recruitment, and patients would be retained for longer times because of convenience. They would have to travel less to conventional trial sites. And trial cohort would be more representative of the nationwide population and more representative of the average socioeconomic status of the whole patient population. So in terms of diversity, equity, and inclusion. Another experience in Japan was published. And this was a phase 2 basket trial of brigatinib in patients with ALK fusion positive tumors. Also, this is a rare tumor type. So in Japan, this center was one of the trial sites, but these areas were very low population density, and to find patients would be very difficult with the traditional way. So they had a network with primary physicians over their whole province. And when they found eligible patients, they did a decentralized clinical trial with the local physician and this trial site doctor with many digital or remote elements using video conference system and delivery. So DCT's oncology has many challenges. New devices can be a burden to patients and physicians. Some in cases they may not prefer remote, video conferences, and higher risk of protocol deviations. And they need to have experienced partner hospitals. So local clinics, they are not used to conducting clinical trials. So to have a very close relationship and a skilled set of partner local clinics needs quite a lot of effort for both sides. But it has benefits for local communities because they can provide access to clinical trials to patients in rural areas, especially less densely populated areas. There was an interesting paper this year by the Oncology Society of Australia. So they suggested a teletrial model. So this was a kind of a special form of DCT. So they mentioned in their paper that full decentralized trial would involve a trial site and community centers and this kind of setup. But they proposed that with a teletrial, so this would be a very specific, special kind of DCT model in which they had a supervision plan for every health institution with a primary site being the overseeing the whole network. And they would have a supervision plan to upgrade the clinical trial related expertise and skills of all their health institutions or satellite sites. So this summarizes when DCT is favorable in oncology. So you could imagine that the left column is using DCT elements, priority for using DCT elements. So safety profile is established. So I'm not saying that the majority of all trials will be using remote elements in the future. No, I don't think that so. So many trial investigators think that even in the future, many early phase or high risk or first in human trials still will be conducted within a traditional clinical trial site. However, even for those kind of traditional trials, if we can use remote technologies to monitor patients while they are at home, for example, between infusion cycles, they spend several weeks at home, but if we could monitor their performance scale automatically using, for example, smartwatches or mobile phones or other kind of technology, it would be very informative and also beneficial for both the patient and the investigational team. And drug logistics, the drug should be stable and able to be self-administered, for example, oral or subcutaneous injectably, self-injectables. Recruitment, straightforward, and the protocol should be not too difficult to standardize between the sites. So we have many regulatory issues and also legislational issues. So in Korea, we have many issues related to conducting DCT, such as Medical Service Act, Pharmaceutical Affairs Act, and also Privacy Act regarding personal information over ICT. And the telemedicine is not allowed in Korea. And in the general global landscape, DCT elements are much more actively used in Northern America and also Europe and Australia. And even in Japan, telemedicine is used quite more actively, but in Korea, unfortunately, not yet. So there are many issues to consider and discuss within this regulatory framework. So 3 years ago, with the initiative of the Minister of Food and Drug Safety, we established a kind of a think tank of experts, multi-panel experts. So we had a public-private partnership between our university and MFDS, Minister of Food and Drug Safety in Korea. And we have been working on many kinds of guidance and recommendations we can use for DCTs. So this is the summary of the layout of the multi-stakeholder collaboration, which we have been establishing. And we hope to have this kind of public-private partnership think tank continuously to discuss many kinds of issues. And I hope many other parties will participate in this kind of discussion. So because this kind of trend is very obvious, because it's the same reason that you can still go to a supermarket to buy some groceries, but sometimes it's convenient just to order online, and we don't have to go to a taxi stand to get a taxi anymore. And also, we can still go to a cinema to watch a movie, but if you don't want to go to cinema, you just want to stay home, and you don't want to, you want to watch it anytime you want, you just watch OTT at home. So this kind of trend is, I think, the same for medicine and also for clinical trials. Okay, with that, I'd like to summarize my talk. Thank you very much for listening.
Okay, thank you. We will hear Professor Yoshikawa's talk, and then we will have a discussion. Yes, it is my great honor to introduce Professor Takagi Yoshikawa. Professor Yoshikawa, he had education, training, and first half of his faculty was Yokohama City, Yokohama City University, yes. And he was also chair at Kanagawa Cancer Hospital, but he moved to as a chief of gastric cancer at the National Cancer Center, and more importantly, he became chairman of Gastric Cancer Committee of JCOG. As you know, JCOG is the most important government-funded research organization, and now he is going to talk on surgical and technological innovations in gastric cancer. Professor Yoshikawa, please.
Thank you very much, kind introduction, Professor Han Kan-yan. And also, it's my great pleasure to have a speech on this meeting. And thank you very much for members and all colleagues of related with this meeting. My topic is surgical and technological innovations for gastric cancer. My talk is not on the clinical trial. I'm very sorry. I prepared 3 topics. The first one is prediction of nodal metastasis. As you know, gastric cancer frequently metastasizes to the lymph node without distant metastasis. For T1, early gastric cancer, lymph node involvement was observed in 20% of the patient, but we can cure it by standard gastrectomy with lymph node dissection for T1 disease. So we can save the patient with T1 gastric cancer. But on the other hand, 80% of the patient had no lymph node metastasis. So 80% of the patient received over surgery and loses their stomach. So we have to save the stomach of course, we have to save the cure the patient. That is achieved by local treatment. But next, we have to save the stomach. So our challenge is to predict the lymph node metastasis in T1 gastric cancer. This is very old study, prediction based on the conventional CT scan. And for predicting the lymph node metastasis, we have to focus on the false negative rate. False negative means predictive N0, but pathological N+. If we rely on this CT scan, 45 patients did not receive gastrectomy, but not cured by such incomplete surgery. So false negative is very important. And next, second priority is false positive. This case, we do the standard gastrectomy with lymph node dissection, but this 6 patient had really no pathological N disease. So standard surgery is unnecessary. So the first priority is false negative, must be 0. And second priority, false positive rate. But anyway, by CT scan, many cases are diagnosed with false negative. So CT scan is unreliable. To increase the accuracy of CT scan, we explored the new statistical model. Firstly, we examined risk factor for nodal metastasis, clinical depth, size, and histology were independent risk factor for nodal metastasis in T1 disease. And using these factors, we can improve the accuracy of prediction like this, false negative and false positive. We can improve the accuracy of prediction, but still imperfect. So this is sentinel lymph node concept. As you know, sentinel lymph nodes is the first lymph nodes drained from the tumor, primary tumor. So if the sentinel node is negative, no any other lymph nodes have lymph metastasis of the tumor. So this is sentinel lymph node concept, which is applicable, maybe applicable in the stomach cancer. And there are 3 big trials to confirm the lymph node, sentinel lymph node concept. And false negative rate here, 7%, 14%, and 0%. Relatively good, but you can see the denominator here, only 57 patients, 28 patients, and only 10 patients. So the reliability of false negative is not still high. So sentinel lymph node concept is very attractive, but we have to wait much more reliable result. Another approach is sentinel node basin dissection, which is the unblocked dissection of the lymph node area involving the sentinel lymph nodes. This is very interesting phase 3 study. Korean surgeons did perform this large-scale phase 3 study to compare the conventional gastrectomy with lymph node dissection and sentinel node basin dissection. By sentinel node basin dissection, many patients can save the stomach. So this is very important study, and primary endpoint was disease-free survival. But unfortunately, sentinel basin dissection it has a relatively inferior survival as compared with conventional standard gastrectomy with lymph node dissection. But overall survival was similar, and this is an event for disease-free survival. And only 2 patients had record from the sentinel node basin dissection. So the event are doubled in the lymph node basin dissection, but really this is very small than expected. So we expect that sentinel node basin dissection would be an option of the treatment for T1 gastric cancer. Another approach is the prediction by AI, artificial intelligence. This is an example. Chinese surgeon published interesting paper and opened in the website. This is very impressive, and you can put the age, gender, location, size, macroscopic type, histology, and invasion, and automatically we can obtain the probability of lymph node metastasis. This is very interesting study, but there are so many papers evaluating the prediction by AI. We also explored the lymph node prediction by AI. Our focus is the false negative should be 0. And in that paper, in the developmental cohort, to set the false negative 0, and we adjust the many clinical factors and validate in the validated cohort. And also we confirmed that false negative was 0. But here is the false positive rate, very high, so still imperfect. So this is just my idea. More precise prediction may be possible by such as endoscopic findings, pathology, or ICG. Many factors could be put in the AI, and we hopefully we can much more precisely predict the nodal metastasis in the future. The next topic is technological innovations. For gastric cancer surgery, the paradigm shift is occurred from open surgery to laparoscopic surgery and robotic surgery. This is a picture of the left gastric artery here. In the minimally invasive surgery, magnified view is obtained by laparoscopy. That is very important for surgeons. Magnified view enabled us to understand precise surgical anatomy and to perform meticulous surgery. So this is short video. This is open surgery. We can't see the precise anatomy. We can't see the precise structure of pancreas here. So we may injure the pancreas in the open surgery. But in the laparoscopic surgery, with a magnified view, we can see the pancreas here. But in the laparoscopic surgery, forceps is straight, and device is straight, and sometimes tremor. My hands is shaking sometimes here. Magnified view is useful for surgeons, but straight forceps and straight device and tremor would worsen for the patient. That is a problem in the laparoscopic surgery. But in the robotic surgery, you can see the articulation of the forceps and no tremor, because the robotic system has tremor prevention, and also 3D view. So these robotic advantage must be beneficial, especially for surgeon. So what is the benefit of minimally invasive surgery as compared with open surgery? Operation time longer in the laparoscopic surgery. That is the merit of laparoscopic surgery. But blood loss is significantly decreased in laparoscopic surgery. That is a benefit for patient. So meticulous surgery may lead to the less blood loss. So looking at the pancreatic fistula incidence, this is open surgery cases, much more high incidence, 2% to 30% is observed by open surgery. In laparoscopic surgery, 0.5 to 12% decreased as compared with open surgery. And in here, robotic surgery, almost 0%. So pancreatic fistula is decreased by meticulous surgery with magnified view. So what is the benefit of robotic surgery versus laparoscopic or open surgery? These are almost RCT or retrospective studies. The operation time is longer than open surgery, longer than laparoscopic surgery, longer than laparoscopic surgery, open surgery. But morbidity seems a little bit lower than laparoscopic surgery here. And also less blood loss, short hospital stay are repeatedly demonstrated in several studies. Again, morbidity seems to be lower than laparoscopic surgery and less blood loss, short hospital stay, but still long operation time as compared with laparoscopic surgery. So benefit of robot, less morbidity, less blood loss, and short hospital stay. But demerit of robot, high cost, and long operation time. So this is our phase 3 study conducted by JCOG, Mona Lisa trial. Any resectable gastric cancer patient are randomized to laparoscopic approach and robotic approach. And primary endpoint is abdominal infectious complications. Our hypothesis is that laparoscopic surgery, abdominal infectious complications is 6%, robotics 3%, and sample size is calculated to be 1,040. And now the patient, almost 1,000 patients were enrolled in this study. We want to see the primary result soon. So long operation time, why? The reason why. Major cause of long operation time by robot is junk time, camera cleaning, and instrumental change, and instrumental change here, and robotic load and adjustment setting, and all of those could lead to the prolonged operation time in the robot surgery. That is a demerit of robotic surgery. So this is a conventional robot, Da Vinci Xi, very large and including 4 arms, occupying the bedside, almost no space for laparoscopic surgeons, assistant, and at least 5 ports are necessary. So now we have Da Vinci SP, single port Da Vinci, only 1 arm and 4 channels. So using this SP system, we have much more space for the assistant or laparoscopic surgeons. And only 1 port is required for Da Vinci SP. Setting is simple and adjustment is simple. So junk time could be shortened by using Da Vinci SP. And we developed a new surgical system, minimally invasive laparoscopic and robotic system, which was published in Asian Journal of Endoscopic Surgery, as called as MIRA. And 1 port for Da Vinci SP, and 2 ports for laparoscopic surgeons. This surgery is cooperative surgery by robotic surgeons and laparoscopic surgeons. This is below view, and below view on the 6th direction, the scope is here, and the retraction arm is here, and on the above view, the scope is here, 12 o'clock direction, and the retraction arm is, retraction forceps is here, and this is the basis of the concept of Da Vinci SP, because otherwise internal conflict easily occurred. And using this concept, 12 o'clock to 6 o'clock, we can have much space for using the forceps for nodal dissection, left side and right-hand side forceps. This is a short video of my surgery using Da Vinci SP. Firstly, we selected below view and retracted the stomach to the anterior side. Here is the laparoscopic forceps here, and device is here. And using 1, 2, 3, 4, 5, we have 5 forceps to create a surgical field, just like this. Of course, the 3 forceps is mandatory to create a surgical field, but 5 forceps is much easier to create much more better surgical view. And this is the video of the number 6 dissection. Here, you can see the right gastroepiploic vein and arteries here. Firstly, we taking down the transverse column, just like this. Retraction arm is here, and laparoscopic forceps is here and here. And 1, 2, 3, 4, 5. We can use 5 surgical hands to do the lymph node dissection, just like this. This video has actually have the voice, but no voice. I'm very sorry. This is right gastroepiploic vein is here. We can expose the root of right gastric vein, just like this, and clipped by the laparoscopic assistant and cut by the ligature, just like this. And then we expose the root of right gastric artery, just like this, and clipped and cut by the ligature by laparoscopic assistant. This is the infrapyloric artery, clipped and cut by the ligature, just like this. And we resect the duodenum. After that, we convert it to the above view. This is above view. Scope is here, and retraction arm is placed on the 6 o'clock direction. And the laparoscopic forceps lifted towards the anterior side, just like this. And we can use left and right hand side for nodal dissection. This is my left hand side. This is right side. Using the double bipolar method, meticulous surgery is possible, just like as a conventional robotic surgery using Da Vinci Xi. But setting is simple, and junk time is simple, and almost no change of forceps. So junk time is shortened. this is a common hepatic artery, and and this is right gastric artery is here, common hepatic artery is here, and we dissect by using the double bipolar method to keep the outermost layer of the artery. This is the root of the right gastric artery. Laparoscopic forceps is here, lifted to the anterior side. Just like this. And the laparoscopic device of ligature here, and clipped and cut by the ligature, just like this. And number 8A, nodal dissection is continued toward the left gastric artery and the celiac artery. We keep the outermost layer. This is a coronary vein, left gastric vein is here, exposed and cut by the ligature by laparoscopic assistant. And this is a root of left gastric artery. Dissect to the right side of the celiac artery to keep the outermost layer of the artery to preserve the nerve fiber along the artery and expose the root of the left gastric artery. Like this. For laparoscopic surgery, we have 3 forceps. In a conventional robotic surgery using XI, 3 forceps. But in the Miller system, we have 4 hands. So more better surgical view is created. Number 11P is dissected, just like this. This is splenic artery, and to the posterior wall of the lesser curvature. And then dissected number 1 and number 3 by ligature and also the double bipolar system, just like this. And the anterior side. And cut the stomach by the stapler. And for the reconstruction, open the small hole in the jejunum and inserted the cartridge hook of the linear stapler and lift it up to the stomach, remnant stomach, and inserted the anvil fork into the remnant stomach and reconstructed by just like this and closed by the barbed suture and made the gastrojejunostomy just like this. I'm sorry. This is our short-term outcome by using the Da Vinci SP. 23 cases were operated by this system, and blood loss 30 milliliter, operation time less than 200 minutes, and no leakage, no pancreatic fistula. Very short operation time is obtained by this surgery. The last topic is objective measurement of surgery. In the Da Vinci 5, the most latest Da Vinci, motion of each instrument and scope provided 3D path, distance, and forces. These digital data were used for the many factors, for example, education or surgical quality, and so on, just like this. This is 3D path. This is a very interesting study to develop and validate the objective performance metrics for robotic-assisted radical prostatectomy. And this is experts example. This is beginners. And each part is here. This is a part for bladder mobilization. For expert, very motion is very simple and efficient. But for beginners, junk motion, many junk motion is was seen by this performance metrics. In other part, just like this, we can see the surgical quality by using this performance metrics. So objective measurement of surgery could be useful for evaluating the surgical quality, possibly related with morbidity. Of course, useful for education by comparing the format of the expert, and may provide a guide, surgical guide, by combining with anatomical image. And in the future, these measurements lead to the autonomous surgery. Thank you for your kind attention.
Thank you very much, Professor Yoshiko. Have said we can have a discussion some time. Yes, yes. Maybe we may first start back to Professor Yu. Yes, about. But let me just quick question to Professor Yu about decentralized. That's good because of now advancement of all the technology and for the convenience, as you nicely demonstrate. So, as a new president of National Cancer Center, I thought about because we have the problem of patient. Yes, so many patients have to come to Seoul, and now to improve that issue, National Cancer Center has 13 regional cancer centers. So, as you may agree, if some centers, doctors who can join clinical trials, we can expect quality of care must be improved too. So, in old days, we always thinking clinical trial. Some patients should come, measure right that side. That's conventional. So I just want to ask you, Professor Ra, Professor Park, about why not try some easy, that decentralized clinical trial, oncology clinical trial with 13 network of regional cancer center. So the reason why I'm suggesting you is that this is very important because, as you mentioned, there's some hurdles or regulation. So by doing this, we can propose some model or some suggestion to improve those without sacrificing accuracy of clinical trial. So you have a Professor Park, and we were very surprised, impressed by your huge, complex network over your, what was the name? Very,
It's a
ARICTT. So as some example trial, could you do that kind of thing? NCC, regional cancer centers, with Professor Ra, Professor Park as an advisory member, you sure be core member of this trial. Could you answer?
Yes, Professor Yang. Yeah, thank you for your question and comments. I think that's a very good way to start because if you have already a established network, it's a very good way to start. And we could start with a kind of either a mock study or a very low risk, very easy kind of feasibility study to check the logistics and quality and the skillfulness of the partner sites. And then from there, we can go on to low risk trials and then to more high risk trials. So I think your suggestion is very good and a very practical, feasible way to start this network. And also, if the regional network also has some facilities nearby, if a patient even has to travel a little bit to the regional facility, the regional center could make a network with the regional local clinics. For example, for a very simple like X-ray or blood pressure or just a simple lab test, those kind of very easy level follow-ups. So I think that kind of networking build-up would be very important and a starting point.
I also have questions and in part comments. So DCT seems to be very attractive, but still there is a problem of technology. So when I think, like you mentioned about that watch or something, I don't wear. So I was worrying if you do that type of DCT decentralized trial, some of the patients who are not used to use those technology or the devices are not being enrolled. So that is a selection of the patients only who are keen to those machines or something. So I was curious, is it really generalized data for that? So I'm a bit of concern about the cancer patient trial. It's good for the cardiology or the benign diseases with many numbers, but cancer patients with very specific issues, I'm still a bit concerned about the system. So I want to hear your comment. And following that, when I hear that DCT, I was thinking about the telesurgery. So that is one of the way you do here and the patient in the suburban area can do. So I want to hear about the surgeon's comment on that telesurgery. Thank you.
Yes, Professor, you raised a very important point about the patient's feasibility and the possibility. Yes, it can be a problem because if we ask even the investigators or the coordinators or the patient, actually they don't want to change. They just want to do traditional way personally, but we know that sometimes it's convenient. And you need to use a new device. You have to log on twice and get used to the new device. But so we're going in that direction, and the device has to be made more friendly. But my short answer would be that for the meanwhile, we could offer an option to the patient. So I think most DCT should be started as a hybrid model, using the traditional method and also providing an option. Would you like to use your smartphone or wearable in addition to the traditional way? In that way, the patient has more autonomy and they can choose. If they don't want to use digital, I just go the analog way. Yeah, so I think that would be needed during the transition period. Thank you.
So I just want to make a short comment on this point about the decentralized clinical trial in oncology. I think, as a breast cancer oncologist, I think the adjuvant trial using the endocrine-based therapy would be a good area to do the decentralized trial because, sometimes patients should make a travel all the way from Busan to Seoul just to injection the GnRH agonist every 4 weeks. So that could be minimized for the patients. So I think the philosophy for the expanding decentralized trial would be the patient centricity might be the core value to expand that program. So, and then we had the small experience with the trastuzumab and pertuzumab combined subcutaneous injection. So the trial checked the patient preference after checking the safety with that drug at the hospital, and then we gave them the chance. Would you like to get injection every 3 weeks at home or at the hospital? And then the patients can to choose the crossover to the other part. And then because patients still likely to have job and work at daytime, so our patients did not want to get injection at home. So which was the different from our expectation. I think like that case, but applying that clinical trial, we had a huge the hurdle in conducting that trial in Korea because of the regulation. So for the home nursing activity, the nurse should be the home nurse. But to inject the IP, the nurse should be the clinical trial coordinator, who should get through all the educational program for the clinical trial. So we had a very hard time, and then we used send out the home nurse and then clinical coordinator at the same time for the trial, which is very expensive trial, could be. So I think I just want to have a question to Professor Yu. How are we close to the conclusive regulatory the protocol by the MFDS for the decentralized trial, just like FDA or EMA in Korea? I think you work very closely to the stakeholders.
Yes, thank you for your comments. Yes, the regulation in Korea, the MFDS is moving slowly but forward to opening those kind. But the fundamental barrier is the Medical Service Act and the Telemedicine, and also the Pharmaceutical Affairs Act, which does not allow direct shipping of drugs to the patient. So those two are the fundamental barriers, but many people are working on. So actually, 2 weeks ago, we had a forum at the Congress in Yeouido. So we could bring some awareness to the public about these kind of issues. So we hope to address these issues, but the progress is relatively slow because of the medical situation.
Yeah, again, this issue was decentralization clinical trial. Again, Korea, we have a big issue of centralization of cancer patient in Seoul. So as you mentioned, yeah, patient-centered. So before we go all the way advanced decentralization, we may, the reason why I said using 13 regional cancer center could provide a little bit safe conduction of decentralized. Yes, it may be, you may say, oh, it is a multi-center trial. No, we try to try decentralization concept and also propose government how to relax the regulations for the patient, how we can do it safely. So I hope Dr. Yu and all of you can use this as some platform to formulate safe way of decentralization clinical trials. Yeah. And let's go back to now Professor Yoshikawa. He is waiting for us. And Yes, Professor Ra asked about telesurgery. Yes, that's one thing I'm pretty sure you have an answer. But before that, because we are here of medical oncology, surgical oncology, and when there's some new drug, such as anti-HER2 antibodies come, already we know that it is good. But another one is it came out, and then we don't use it immediate to the patient. We test it with comparing with a conventional. So that's the way how you have done, we all surgeons done open versus laparoscope, and the laparoscope versus robotic. But when we have a new device here, for example, you said Mona Lisa studies comparing conventional robot surgery versus conventional laparoscope surgery. Now we have SP, single port surgery. That's a very advanced device. But what we have to do, isn't it considered a new therapeutic agent? So don't we need some study? And then probably you agree, yeah, compare with the conventional robotic surgery. Then there's a cost, money because it's a new device. So you have to buy this expensive device, $2 million, and patient paid more, or government should pay more for the insurance reimbursement. In that situation, medical oncologists, they do not hesitate to do clinical study supported by the manufacturer. So what about in Japan?
Thank you very much for very difficult question. I think the more new device, and theoretically that new device has benefit for the patient, we should do the new clinical trial comparing new device and old device for the patient. Scientific evidence is necessary for the patient. That is my answer.
How about telesurgery?
Yes. In the clinical trial, of course, surgical quality is very important, especially in the surgical trial. Surgical quality is very much important. And telesurgery is maybe a good way to in the decentralized clinical trial. But in Japan, we have many localized cancer centers, all covering the Japan, many cancer centers. We don't need telesurgery now. Each region is covered by each regional cancer center. The patient can easily go to the regional cancer center. So my opinion is that the DCT, decentralized the clinical trial, is impressive and attractive. But in Japan, at least in the surgical clinical trial, DCT is not so useful. Surgical quality must be important. Of course, telesurgery is maybe the one answer to do the DCT. But in telesurgery, we have to solve many problems such as regulation, who had a responsibility to do the surgery, very, very nervous problem have to be solved.
Yeah. For your information, whenever robotic devices came in, Seoul National, we always persuaded the manufacturer to invest some money to test at least a very phase 1, phase 2, but this is actually it is necessary because now more companies are coming with the devices. And the number 2, telesurgery. Yes, in Japan, yes, it is a standardized regional, so it is not necessary to perform, but it is studied because at least it can be used for the telementoring. Somebody operating there, and expert like Professor Yoshikawa can devise some comment on certain procedure, or even he can intervention. He can join with that console. He can control in his office the patient in another place. Actually, that was tested 2000. Dr. Jacques Maresco in New York, he performed a cholecystectomy. His patients in Strasbourg, France. So this is certainly our near future. Countries like China, Mongolia, big countries. Yes, yes, please.
I'm not a surgeon, so I have a question to Professor Lee. So I think to do the remote surgery, the hospitals should have the 5G operation room, yeah, for the real-time operation from the remote. So do you have that kind of futuristic operation room at your institution?
Thank you for your question. I'm Hyuk-jun Lee from Seoul National University Hospital. I'm also a GI surgeon. As Professor Yoshikawa and Professor Han Kwang-yang mentioned, I'm not a fan for the remote surgery. And maybe most of surgeons do not want to do the remote surgery in terms of patient safety itself, as well as the always the surgeon, the driver of the operation should stand just nearby the patient to prepare something happens to control that issue. And as Professor Yang mentioned, the educational purpose is possible, but that is not an ideal way, in my opinion. In terms of decentralized clinical trial, the surgeon's point of view, I think the follow-up will be one possibility of include that trial, because some of the patients that live very long. America and China, some big countries, they are using the social network system for their status, they are alive or they dying or something. So I think that's until now, the only limitation, only the utilizing focus of that trial. Can I make a short question to the Professor Yoshikawa? I'm interested in your Mona Lisa trial. You already collected about 1,000 patients very quickly. I'm very surprised, and I want to see the final result. And always Korean gastric cancer surgeons are curious about why your previous observational study shows the lower incidence of complication in robot compared to laparoscope, and you also expect lower incidence of morbidity. But our Korean data always shows that no difference in robot versus laparoscopic surgery. So my question to you is, you are checking the Krabbe-Dindo 2 or more complication, especially focusing on the pancreatic fistula. So what is the definition of a pancreatic fistula? This is just the elevation of drain amylase level or any clinical manifestation of the pancreatitis. And how do you determine the starting of antibiotics in this pancreatic fistula patient? Because this is very important. You know that who receive robot, who receive laparoscope, and if you start antibiotics, that patient is a complicated patient. That's my question.
Very good question. Thank you very much. And yes, diagnosis of pancreatitis is depending on each physician. If the patient had a fever or abdominal pain, we take the CT scan for the patient, and fluid correction is surrounding the pancreas, and some increases density, fat density. We can diagnose that patient as pancreatitis. Of course, amylase level is useful for the pancreatic fistula, but for the infection of pancreatic fistula, may need fever and CT scan and physician's findings. But we don't have any definition to diagnose pancreatitis in that protocol. No, no.
Thank you very much.
Good question.
Okay, okay. So I'd like to appreciate for your wonderful talks from Dr. Yoshikawa and Professor Yu. And I also thank to Professor Hyuk-jun Lee for your contribution. I'd like to close this session. Thank you.
We have 20 minutes behind the schedule, but we will have a 10 minutes break. So the last session will start 10 minutes later, 4:40 p.m. Thank you.
갔다 오는
Do you need the water? Yeah.
Yes.
You can take that.
감사합니다.
커피 버릴 때 밖으로 나가시면 돼요. 화장실에 쓰레기통이 있어요.
us sit, please. So, the last session, difference in Eastern and Western views on Eunaesthesia, Eastern philosophy session will be moderated by Professor Yoon-Seok Go from Assam Medical Center. Professor Go, please.
Good afternoon, everyone. I'm Yoon-Seok Go, working at Assam Medical Center. And this third session is about issues on end-of-life care in Northeast three countries. And it is our luck to invite three renowned speakers for this topic. And the first speaker is Professor Il-Hak Lee. Il-Hak Lee is an associate professor at the Department of Medical Humanities and Social Medicine at Yonsei University College of Medicine. He is quite expert, especially in our study to enhance end-of-life care in our society. And particularly since 2018, he has been collaborating with the researchers from University of Bristol in the UK and the Kyoto University in Japan on a Bridge Bristol Kyoto Yonsei project. He will talk on debate about assisted dying in South Korea. Please.
Good afternoon, everyone, and thank you, First Chair, for introducing me. I am so honored to have a chance to speak here and introduce some ideas and perspectives about medical aids in dying. Actually, the medical aid in dying has different names according to cultures. Like in United States, they prefer the name MAID, medical aid in dying, or in UK, they prefer the name as assist dying. Or in South Korea, still we prefer the name assist suicide. So those names reflect some ideas or attitude toward some medical intervention at the last days of life. And especially, I'll talk about what's going on in South Korea nowadays. Last July, Korean Parliament, there is a legislative bill was issued. The name is Assisted Death with Dignity. And it is said that the purpose of this legislative bill is to legalize. Okay. Am I loud and clear? Okay. The bill said that the purpose of this bill is to legalize assisted death with dignity, enabling individuals determined to be candidates for assisted dying due to their status as patients with no possibility of recovery to end their lives autonomously with the assistance of their attending physician. Their aim is to respect personal autonomy and ensure a dignified death. And as about this bill, a public poll was performed several times. This graphic is the result of a survey performed in last year, July. Also, similar bill was submitted to Parliament at the time. And according to this report, majority of the population agreed to legislation. It means that they agree to legalize, they agree to permit physicians to attend in assisted suicide or hastening the lives of a very sick person. And it is very easy to imagine that the people's responsibility. People's response to this bill is quite various and also quite diverse. And the bill has several clauses about the possibility and the safeguard. The first thing is the bill says the patient condition as a first criteria or first standard of allowing assisted dying, that the patient is very sick and there is no possibility of recovery and he is suffering very much. And also he must be autonomous and very competent to express his will or her will about assisted dying. But at the same time, like other legislations, there is a safeguards against some abuse or misuse. So the bill says that the national agency will establish and the operation medical ethics committee in every hospitals. So those hospital ethics committee will oversee what's going on and they will consult and supervise those patients. And also they want to establish or legalize the review committee. And also it provides physicians some consensus objections to this. But it looks fine. But at the same time, do we have some questions whether Koreans are open to this change or they are willing to accept this kind of new legislation and new medical practice of assisted dying. So it is very many cited results by the professor in hospice and palliative care. According to this research, that about almost 80% of the population agree to legislation of this assisted dying bill. But when we survey or other society, it is an Hospice and Palliative Care Association of South Korea has done with different questionnaires, the answer is quite different from the simple questionnaire. Although many people agree to legalize or they are open to the possibility of assisted dying, but when they asked about the priority about end-of-life care, they choose as a fourth, not the first or second one. They prefer, sorry it's Korean, but they prefer about the financial burden. And they also talk about this financial support because it is a huge burden for individuals with the end of life, at the end of life, about their the expenses. And also finally the third, and I think it is quite similar in their response rate. So it is also important, is increasing hospice and palliative care service in South Korea. So it may not be the case that many Koreans are open to legalize or legislation of assisted dying. So we can interpret these different surveys and different intention and different some result as like this. Citizens do not distinguish between the cessation of the futile life-sustaining treatment like natural death or death with dignity with MAID. They think that assisted dying is a same name with natural death. So it is a point. Their attitude reflects a desire to alleviate the suffering of patient, and they perceive good care as a means to achieve this. So, and while also it suggests that citizens view euthanasia as a potential choice only after such a good palliative care is provided. So we'll go back to these points later in my presentation, but I want to emphasize that assisted dying is a part of good palliative care, not a way, an easy steps to achieve a good death or good end-of-life care. So there are huge debates among some bioethicists or public. So some people regard assisted dying as excuse for suicide. So even some people say assisted dying is pushing the vulnerable into death. But meanwhile, there are other people, including me, that the assist dying is a way or the expression of autonomy. It is an expression or implementation of rights to autonomy. So these two things, I think it is not different if we see from some higher level. But from current standpoint, it is quite different, looks like. So something is missing. So I think that there are some action or some activities to define and what's the values we are talking about, would be the best practice, or what do we think about, and sharing our opinions. But to achieve this, or if we are to think about legislation, or if we are to set up a good practice of end-of-life care, then we need public deliberation. It means that we are as an equal citizens and with our own perspective, share our opinions and think and consider deeply about the limitation or the meaning of assist dying. So there is a long history from the late 1990s until now, from landmark cases like Broame Hospital case and Severance Kim Harmony Grandma Kim case. And finally, End-of-Life Care Decision Act was enacted in 2016. But still there is a concern that good end-of-life care is not provided for our patients. Meanwhile, but in this context, the assist dying is suggested. So there is some concern. I think it is quite reasonable concern. So also there is some context of this kind of suggestion and this kind of welcoming attitude of a public, like the Korean society is becoming aged. And also family structure is changing, that usually elderly parents are taken care of by their children. It is a responsibility of the offsprings to take care of their elderly parents. But now the family structure is changing. Also their attitude toward this filial duty is changing. So they don't regard as a legitimate responsibility to take a burden. So elderly patient feels that they are abandoned. Sometimes they feel they are quite useless, or they don't know what to do. And also it has some connection with a prolonged end-of-life care. We provide very good acute care, and we are providing very good cancer management. But we don't, it is very sorry to say, but we don't, and we haven't provided decent end-of-life care, not very sufficiently. So, and also there is some concern about resource allocation. Actually, there is some kind of pressure for national healthcare system. So there is some concerns that elderly population is pressured, and there is some statistics. You may know that the Korean elderly suicide is a social problem. It is highest among the world, not just younger generation. Also the elderly suicide is a quite huge problem, and mostly it is related to their health status and their feels of abandonment. So there is some considerations about the elderly suicide, but I don't want to ponder on this. But anyway, but I would say the assist dying or aging dying is not assisting suicide and should not. So it must be provided at the same time with a good end-of-life care, good hospice care. So this is some ethical context or environment of South Korea about assist dying. There is a penal code that banned any assist in suicide. So it will be punished as in the assisted suicide. But at the same time, there is some constitutional interpretation that it is one of people's basic human rights to choose what is best for their lives, what constitutes to their happiness and welfare. It includes, I think, to end their own lives. So there is a lawsuit is filed on Constitutional Court about not legalizing assisted dying is not fulfilling governmental responsibility. It is filed and it is still undergoing the consideration. So, and also there is some debate or there is some discussion about condition for permissible assisted dying is that terminal stage, informed considered decision, and also as a safeguard and medical evaluation. And public engagement must be accompanied during the social deliberation. But anyway, public is widely support, it seems that, but medical professionals are reserved in many respects. They are concerned about the misuse and abuse. And also, it is not a priority to legislate assisted dying. So there is another point that we need to focus, that like we need a clear concept. We are now moving from passive euthanasia to active engagement. So what it incorporates in our concept. And also we need clear standards of what is terminal stage of a disease. It depends on the type of disease itself, because many diseases has different trajectory. So we don't have a single clear ideas about the terminal stage of a disease. So we need more some like education or learning about what's going on at the end of life. And also we must set up some safeguard against some misuse. And also during this stage or during this act, we need patient participation, and also we need to set up a very good and acceptable best end of life care practice. Like it will include advanced care planning and quality palliative care. And also, I think it is very important from now on, still in South Korea, we don't allow patients to refuse a treatment. It is not culturally, it is regarded as inappropriate refusing treatment. So we need to gather some public understanding about this right. And this is my point of this talk, is that assisted dying should provide it alongside with the hospice and palliative care. It means that MAID or assisted dying should not necessarily be seen as a concept competing with hospice palliative care. Some people regard it as this, but rather as an independent yet interconnected component of holistic care. So assisted dying could and should be understood as a way to alleviating the pain or incurable suffering of a patient. And concerning attending physician who take care and good relationship with the patient has a duty or responsibility to discuss about the possibility of assisted dying with his or her patient and allow or help them to make an informed choice. And if we think that it is time to allow and it is quite reasonable choice, then they could help, like some bill says. But the point is, still we are not alive there in South Korea. We need more palliative care. We need a good hospice care facility. It should be increased. So, And also, to achieve this, as we scholars in medicine, we need evidence, and we are people making evidence. So also, aging dying, autism dying needs for the empirical research to support any policies. And I think it includes trajectory, what kind of disease experience patient has, and also what education helps the physicians and healthcare professionals and patients to understand and prepare themselves. And also we need broader and more clear and well-structured surveys about people's attitude and understanding. And also we need, if we set up any policy, the policy must be evaluated about their consequences and their effects. And also we need caregiver-focused research, especially the children and the caregiver of a patient, and studies on unsupported individuals. They could be a subject or the victim of a not well-designed policy or institutions. And so also this kind of activity should be future-focused one. So this is something I made. Thank you for listening.
Thank you, Professor Lee, for your informative and perspective presentation on medical aid in dying, which is a quite uprising issues in our society. Let's move in at the second topic. Another two speakers will present online. The second speaker is Professor Norio Higuchi. He is the professor of law, University of Tokyo Law Department until 2017. And he will present on the end-of-life care decision-making, a Japanese way of law and medical ethics. Please.
Hello. My name is Norio Higuchi, Professor Emeritus, University of Tokyo, Japan. It's a great pleasure and great honor for me to have a chance to make this presentation, which is on the issue of common interest and very serious one, end-of-life care decision-making. I'll explain about a Japanese way of law and medical ethics on this issue. The contents of my presentation is as follows. Well, first, I'll explain about the law on the euthanasia in Japan. Euthanasia has many meanings, and I have a particular meaning of that. The second, process-oriented and guideline approach from 2007 in Japan needs explained. And the third, death with dignity for advanced care planning. That's the key word currently in Japan. And fourth, no physician-assisted dying, PAD, in Japan, at least currently. Those are contents. And the points and important things about my presentation is summarily as follows. The points are 4 or 3. The first one is no statutes in Japan, but guideline is followed. And second, no substantive rules, but process guidelines are respected in Japan, which means on the medical things about the end-of-life care, substantive decision-making is very hard. What should be done what is just. Those are very important, but very hard to decide. So in Japan, we decided to go on the another way, which is how we lead to a conclusion of this difficult issue. So, I mean, not what, but how. And thirdly, no serious discussion about PAD, physician-assisted dying. Physician-assisted dying is clearly distinguished in Japan from the termination of the life-prolonging measures. And those are important things. And with regard to the third issue, medical professions and lawyers in Japan both agree that PAD is currently illegal, both illegal and unethical. So, let's get into the contents of my presentation. The first one is, what kind of end of care issue is decided in Japan, which is separated from two periods. And the first period is until 2007. And at that time, among the physicians especially, the fear of criminal law intervention was prevalent. And at that time, until very recently, 2007, the termination of life-prolonging measures, such as artificial respirators, could be criminalized, they believe. Japanese police and prosecution investigates into the medical procedure to make this termination a murder, they believed. So in several cases, the intervention or investigation occurred, which gave great fear among the physicians in Japan. And in 2000, I should say, but to take note, only 2 cases are prosecuted. So only 2, but still several others are investigated. In 2006, Imizu City Hospital in Japan, the northern part, there is a city hospital, and Imizu City Hospital incident, we call it, occurred, which became a sort of national scandal. In that case, a surgeon made the termination of the end-of-life care, which resulted in several patients died. But they were with the family consent, which lasted, almost 7 years, and maybe 5 or 6 patients died. Well, I should say peacefully. But police investigated into it and became a national scandal in 2006. And at that time, health minister in Japan made clear that we will need some basic guideline for this issue. At least only one surgeon decided on this. That's a problem. Maybe it will give rise to a great suspicion among the medical fields. And so that's why in 2007 or 2006, the health minister made up an advisory or guideline making committee among the physicians and lawyers and representative of the physicians. On the other hand, what did our parliament did? And they did something at that time. Parliament members prepared for a draft bill in 2012 and 2014, but no submission to the parliament was made. So no acts was made in Japan. And why? Because medical professionals and legal professionals alike both criticized the draft bill. And why criticizing the draft bill? This is just like a statute. It's a one-size-fits-all type of the draft bill. So very formalistic. And lawyers and medical professions believe that end-of-life care for each person varies very widely. So the more important things each person should prepare for the end of life. That is more important, we would say. And the guideline is, we call it soft law, is more soft touch and would fit for Japanese situation, they believed. And so 2007, the so-called process guideline was issued on the end of life care by Health Ministry. And it had a strong effect and a strong influence. And there are 3 points. First, in that guideline, which says strongly, most important one is the wish and self-determination of the patient, whether he or she wants life-prolonging measures. That's the most basic one. The secondly, patient, family, and friends confer and consult with medical professionals about what to do and how long the life should extend. So the only patient should not be left behind. Family and friends and medical professionals got together with the patient to think about the end-of-life care. And thirdly, if patient cannot express his or her wish at the end stage, and then family or friends, and even family or friends do not know it, the true wish of the patient, then the decision should be made by the best interest test judged by medical professionals. That's the core points of the process guidelines. And surprisingly, I believe not surprisingly in Japan, since then, no involvement or intervention by the police or prosecution with regard to the end-of-life care decision-making. And secondly, maybe this is more important. As a Japanese society, as you know, becomes a super aging society, which means that about 30% of people in Japan is now 65 years or older. So very, very aging society we do have. Then the much more important issue we should face, which is, thirdly, how advanced care planning for the end of care as well as the second life longing period is realized among the most people And also the health ministry emphasizes we should make a procedure of advanced care planning for the preparation of the latter life, long life. So the problem we should face is how we could have a better quality of life, QOL, in the aging second life period. And nowadays, most hospitals and elderly homes in Japan says they made up the opportunity for advanced care planning. And by the way, we have quotes. So regarding the quotes, I should take a note. Supreme Court made a judgment, very important judgment in 2008. And the Supreme Court held the physician guilty who put off the life-prolonging tubes because of she lacked two requirements for the legally appropriate procedures in the end-of-life care, which means that if two requirements are satisfied, the Supreme Court suggested the removal of the tubes could be legal and appropriate and ethical. What are the two requirements? The first, the correct and appropriate medical judgment of the terminal illness judged by the medical team, medical professionals, not only one. And secondly, based on the correct information of the incurable terminal illness, then the patient, or if the patient is unconscious, then family consents to the removal of life-prolonging measures. So those are two requirements. For the court says these two are required and satisfied, then the termination is legal, the Supreme Court said. And also, the informed consent doctrine prevails in Japanese medicine and lawyers' world. We believe in informed consent. Informed consent is good and is required in the medical practice. And if we seriously believed in informed consent doctrine, then termination of the end-of-life care is legitimized or correct, about correct. This doctrine requires the patient's consent to any medical measures, including the life-prolonging ones. So it requires that patient, and also it says it requires that the patient freely revokes or withdraws the original consent. Accordingly, if you believe in the informed consent doctrine seriously in Japan and ethically, the removal of life-prolonging measures with the patient's wishes or family's wishes in some cases could not be criminally responsible. Rather, in currently Japan, much more important is how each person lives a good quality of life, even in the end-of-life stage. So palliative care is more important. And finally, I made a point about the PAD. I know that in some countries, in foreign countries, PAD became familiar, or much more familiar or legalized in some countries. In 2019, a Japanese woman went to Switzerland to have PAD. And this woman has serious illness, incurable. And she decided to go on to Switzerland, where PAD is legalized. And NHK TV, national TV in Japan, made up a documentation about her and broadcasted this in 2019. A Japanese woman got a PAD in Switzerland and died. However, no serious discussion about PAD occurred since then, because medical professions and most lawyers agree that it is illegal and unethical. They fear, this is, I believe, really important. The fear in Japan is that as we live in this super aging society, if PAD could be legalized, this might make a social pressure that older persons with serious illness should choose PAD if it is legal or regarded as ethical. The social pressure, not the self-determination, real self-determination by the patient. That's our fear, our society's fear. And I repeat the points I made today is the characteristics of Japanese care, law and medical ethics and law on the end of life care. No statutes, but guidelines are followed. I know that in Korea or in other countries, they made up statutes with regard to that, with the name of the dignity with the death with dignity statute. But in Japan, we have a different situation. Guidelines are followed. And secondly, why guidelines? No substantive rules we do have, but process guidelines we do have. Not what, but how. Is the appropriate way, currently, at least currently in Japan. And with regard to the physician-assisted dying, no serious discussion has occurred, because medical professions and lawyers both agree that PAD is illegal and unethical. So we made a clear distinction between PAD and termination of life-prolonging measures. And PAD is unethical and illegal, but termination is ethical and legal with due process. So under PAD, physicians are more active in giving fatal prescriptions, which could be distinguished from termination among the Japanese people of medical measures. But I wonder it could be in the future, because two reasons we do have. If more and more other countries recognize PAD, then it would be more easy for Japanese to go there to have it. This is a global world. So more and more Japanese might make a travel to have a PAD to foreign countries if more and more other countries recognize it, and which is influencing Japanese situation as well in the future. And also, secondly, right to die painlessly and peacefully might be recognized as ethics may change. Ethics and law would change sometimes, even in Japan. So there is a possibility of change. But in that case, I believe we need a statute, not a guideline to do so, even in Japan, because it is beyond medical judgment or medical sphere. So real things would be prevalent. So I repeat and again, thanks for this precious opportunity to make, for me to make this opportunity to make a presentation. Thank you very much for your kind attention.
Thank you, Professor Higuchi, for your very clear and concise presentation on the current end-of-life care in Japanese society. Professor Higuchi, we are going to have the question and answer sessions after the panel discussion. Could you wait another minute for the question and answer sessions? Professor Higuchi, are you there?
Yes.
So could
I can wait.
Yeah, could you wait? Okay.
Oh, yes.
Okay,
no problem.
Okay, thank you. So let's move in the last talk. The last talk is on the facing death together with the terminally ill cancer patient. A medical oncologist point of view will be presented by Professor Jong-ju Lin. He is the current clinical associate professor and attending physician, Department of Oncology, National Taiwan University Cancer Center. Please.
Thank you very much for your kind introduction, Professor Gao. And dear colleagues, good afternoon. It's a great honor for me to share some of my experience and reflection on accompanying patient with terminal cancer throughout of my career as a medical oncologist. And unfortunately, I'm unable to be with you in person due to the heavy snow in Seoul, which has caused flights from Taipei to be canceled in this morning. Actually, I have been to Taipei airport, but returned to my hospital. And as a result, I'm joining you via this online Zoom meeting. And today's topic, facing death together with those patients, is not only a medical challenge, but also a difficult emotion test. Today, I will present 3 cases and hoping to spark your resonance and the discussion. And the treatment goal for cancer patients can be categorized into several different levels as illustrated in this figure. While our ultimate hope is to cure all the patients biologically, it is important to remember the word of William Osler, to cure sometimes, to relieve often, and to comfort always. For many cancer patients, particularly those in the terminal stage, receiving treatment with compassion and humanity and maintain dignity may be more fundamental and significant than the pursuit of a cure. And here are some key points on how to support and provide comfort to terminal cancer patients. First, it is important to remain present. Sometimes simple companionship offers the best comfort. And we also need to avoid inappropriate comparison and false optimism. We should help those terminal cancer patients face reality honestly. Additionally, patients may struggle to express their need, so we should actively provide our assistance and further encouraging patients to participate in activities. This can make them feel that life remains meaningful or even enjoyable. And don't be afraid to talk about the topic and let it difficult. Frank communication can build trust between those patients with us. Finally, allow yourself to experience complex emotion and strive to stay balanced. Caring for terminal cancer patients can be emotionally exhausting, and it is important to take care of ourselves as well. And now I would like to present the first patient. I name it a hard landing airplane. He is a 45 years old man and a businessman living in China with mainland spouse and a 5-year-old son. And his sister died of lung cancer with massive bleeding under my medical care 6 months earlier. And he was diagnosed with severe liver cancer in China. And he soon decided to come back to Taiwan searching for medical treatment. And he presented with severe jaundice. It is a poor prognostic sign for liver cancer patients. And his Taiwan families refused to discuss end-of-life issues. I think that may be due to his young age and some for the financial reason, because he had a mainland spouse. And the patient himself asked aggressive medical treatment, but he did not request explaining the disease prognosis and the upcoming deaths. He did not ask me or even request any information about this. So ideally, we wish our patients with terminal cancers can have the disease courses like an airplane approaching the airport that will smoothly go to the final destination. However, if the patient did not know the truth, then he may request all the party, including patient, physicians, and the family member may decide together to apply aggressive medical treatment or even resuscitation. Then the patient will have fluctuated disease courses, and like an airplane, then finally it will cause an emotionally crash. And regarding the ethical dilemma, this study is conducted by Professor Cho Tai-yuan. He is current Minister of Health and Welfare in Taiwan. He is a professor in National Taiwan University, a family doctor. And the frequency of different ethical dilemma is shown in this table, which variable is categorized as into two types. One is the issues related to clinical treatment. The other is issues related to mutual communications. And the first case I reported above represents a common encountered clinical scenario. And as indicated in this table, telling truth ranked first among all the ethical dilemma is a difficult situation to telling truth for those patients with very poor prognosis, for the family member and even physician. And this is another study conducted by investigators from Korea, Japan, and Taiwan. This study demonstrated the cultural difference can influence behavior as patient's death approaches. And regarding the trend of family being reluctant to participate in end-of-life discussion, the family from Taiwan show the highest percentage of reluctance. And the reason explaining for the reluctance to discuss end of life is shown here. And on the other hand, having the oldest family member bad news and all family members to present at the time of patient death were significantly more frequently observed in Korea, Taiwan than in Japan. And in terms of concept of filial piety, 孝顺, there were a significant different trend among the 3 Asian countries. And here's come the second patient. This is a patient with lung cancer and with poor prognosis. However, he has an unreasonably aggressive family member, his son. One of his sons is a medical doctor. And before an unfortunate event, a palliative treatment plan had been made after thorough discussion between physician, patient, and families. However, one day the patient was brought to the emergency department in a state of all-hospital cardiac arrest, and his son, the physician, requested aggressive medical treatment, cardiopulmonary resuscitation, and even resume aggressive chemotherapy for his intubated father. Finally, we learned that his son, he's a physician. He prescribed excessive painkiller for his father, and which led to perforated peptic ulcers and the disastrous event. Is unfortunate. And regarding factors affecting end-of-life discussion and disagreement may arise among physicians, among family members, and the conflict may be generated between any two parts of the 3 relevant parties. And furthermore, this conflict may be exacerbated by the patient's impending death and by any other reasons as illustrated in our second cases. And how to resolve this problem? Repeated and thoughtful conversation between patient, family member, and the patient themselves and the physician can help resolve these tough problems. And regardless the established rapport between patient and the oncologist, numerous ethical challenges can arise when the patient enters the terminal phases of their illness. And this challenge including questions about whether it is worthy to request a non-beneficial intervention, the appropriate use of analgesics, and the decision to withdraw life-sustaining therapies. And taking the second case as an example, the request for non-beneficial anti-cancer treatment may come from therapeutic illusion and even from misconduct and the subsequent guilty feelings of the patient's physician son. To resolve these ethical and emotional conflicts, I think close observation and long-term good rapport and in-depth communication are important and helpful. And we should prepare the terminal cancer patient to transit smoothly toward the inevitable end of life. The first is to well recognize that the patient has reached the end stage of their disease. And furthermore, effective communication between patient and the physician and family is essential. Explaining the treatment option and the possible outcome, as well as the cardiopulmonary resuscitation, are crucial. Finally, helping patient and family make informed decisions through advanced care planning will become increasingly adopted in the future. However, the percentage really performed in Taiwan and in Japan is still low. And advanced care planning in Taiwan is based on Patient Autonomy Right Act, which was passed by our legislature in 2015 to ensure the patient had the right to know, choose, make decision, and retain the rights for reach a good death for this patient. And advanced care planning is a thorough process of discussion to discuss the patient's own value and benefit and ensure they understand the different treatment of choices and the potential outcome and what they can do. Let the patient autonomously choose what they want and what they don't want. After this thorough process, the patient and key family member and healthcare providers can co-sign a written advanced directive document, which will be recorded on the electronic health insurance card in Taiwan. And the case number 3 is a patient with curable malignancy. However, she requested in euthanasia. Actually, he requested physician aid dying. This is a 52-year-old female patient with bulky mediastinal non-Hodgkin lymphoma. Is a curable but dangerous disease. And we administer the multi-modality treatment incorporating chemotherapy, intense, and radiotherapy for her, aiming to cure his lymphoma. And she experienced several episodes of life-threatening side effects, even under very strong and good care. And her quality of life was very poor during the active cancer treatment period. And unexpectedly, one day she come to my clinic and request a medical certificate to apply the physician-aided suicide service in Switzerland by the end of that cycle of her anti-active cancer treatments. And currently, he is still alive. She is still alive, free from any cancers or any treatment-related consequence. 17 years after completing all the anti-cancer treatment. So it is a case to oppose the concept of euthanasia or even or physician-assisted suicide. And euthanasia or physician-assisted suicide are highly controversial issues, as you know, in many countries, including Taiwan. Both supporter and opponent insist some point of view in these issues. And paradoxically, both the supporter and the opponent take their action as respecting the dignity of life. And the opponent also think that false autonomy, patient autonomy, may mislead the patient into choosing early death. Second, they think the majority of patient suffering are relievable with modern medical care. And finally, the slippery slope effect could lead to a gradual devaluation of human life and subsequently encroach on the vulnerable population. If we fully accept the concept of euthanasia. And for the supporters, they respecting patient autonomy is a crucial component for their medical ethics. They also feel that choosing euthanasia is maybe the only way to relieve the cruel and endless suffering for those patients with terminal cancers. And as a senior medical oncologist, I would like to share some of my personal position on these issues. First, I believe that we must respect the patient and family requests. And however, I and almost all my colleagues I know in Taiwan believe that we cannot support euthanasia or physician-assisted suicide. Our primary mission is to do our best to relieve the suffering of our patients. Also, we do not support euthanasia. We must ensure our patients have the success to professional hospice care, and specifically, sometimes we were meticulous. We sometimes were meticulously provide palliative sedation for the patients in the critical end stages. And all these views are in concordance with the position of Taiwan Academy of Hospice Palliative Medicine. And as we conclude, I would like to emphasize a few key points. And firstly, the word of William Osler reminds us that our roles are not only to cure, but also to provide relief and comfort. Also, ethical challenge frequently arise in taking care of this patient, and effective communication and advanced care planning are crucial to help those patients and their family to have better experience in end of life. And while we must respect the patient and families' request for euthanasia, but we should acknowledge this is a complex and controversial issues. And after presenting such an important but serious topic, I would like to share a joyful picture. Baseball is a very popular sport in Korea, Japan, Taiwan, and many other countries. This week, the Taiwanese national baseball team won the historical championship in the Premier 12 tournament. Now, all those players are regarded as national heroes in Taiwan. Our president, William Lai, he's a medical doctor and nephrologist, welcomed the national hero home in the presidential office. While I show this picture, I hope that all of us, our patients and their family, can experience the beauty of life right up until we reach the final destination. Thank you very much.
Thank you, Professor Lin, for sharing your personal and your society perspective on the physician-assisted suicide, and also thank you to address the relevant issues and the hurdles related to end-of-life care in Taiwan. I would like now invite Professor Ok-Ju Kim for panel discussions. She is working at Department of Medical Humanities, right?
Yep.
In Seoul National University, and she was the ex-president of Korean Society of Bioethics. Please.
Yeah, thank you very much. We had a very good presentation from 3 countries, Korea, Japan, and Taiwan. Why we discuss about this physician-assisted dying in 3 countries? What's the commonness among our 3 countries? I think this is a Confucian culture. And then in Korea, we said 의술은 인술, which means medical art is benevolent art. I think Japan has also same words, and also China and Taiwan has the same words, that 의술은 인술. So that is has quite a long history. It's from the Confucian culture that the Mencus and also Confucius said that the most basic humanity is that compassion. Compassion is very important. So this culture of physicians and medical arts are quite different. I have my close friend, when I was served as a UNESCO Bioethics Committee, the Bioethics Committee chair was Hans, Dutch physician. And he said, when we first start talking about the physician-assisted suicide in Netherlands, they was very seriously discussing about that topic with patients and other people. But after a generation later, currently, young doctors tend to say, when patients said, oh, I want to have physician-assisted suicide, and then the young doctors tend to say, oh, when? So they do not question about the seriousness and just when do you want? So, but that kind of culture is very unlikely happen in East Asia culture because medical business, medical art is really an art of benevolence. So as we heard, we 3 countries report, we can say that there are commonness because we have a Confucian culture, and also we have all shared the tradition of family-centered decision. Family-centeredness is very important. So as individual self, we think about the family, and then the bigger self is more important to make certain decision. But as we hear the 3 discussion, I think there are certain differences among the 3 countries. Japan, both physician-assisted suicide and euthanasia are illegal. However, passive euthanasia, I mean, I would like to use the more scientific term, passive euthanasia, where treatment is withdrawn and then a patient die naturally is allowed under certain conditions, as we heard from the presenter today. And this is because the Japanese society has tendency to respect the autonomy of patient, terminally ill patient. But as you heard, that the physician-assisted suicide deaths are quite reserved in both legal society and the doctor society. And we can see that Japanese society has strong Confucian and Buddhist influence. So they have dominant view that life is inherently sacred. Life is very sacred, it has sanctity. So, and also there are family-centered decision-making culture, and also growing emphasis on pain relief for patients become more prevalent. So quality of life and advanced care planning is very important. And South Korea, both physician-assisted suicide and active euthanasia is illegal, and it's very unacceptable. If you remember Dr. Lee's presentation, very interestingly, 50% of physicians are opposed to the idea of assist dying, but 80% of public tend to agree of that idea. So that means that the medical field are more resistant to the idea that doctors are helping to make people die. It's very unacceptable, more likely among physicians than the public. And so if you see that Taiwan, I think the later part of the presentation is very important. Taiwan's, we have, as you heard, that we have End of Life Decision Act, which started to work in 2018, but it's very limited. It's only those people who are foreseeable their deaths within 2 weeks. That means dying patient, only you can make your decision only when you are almost die. That is not respecting patient autonomy. So bioethicists and medical ethicists are very much active in voicing. But Taiwan, the Patient Autonomy Act, which was passed 16 and began to work at 19, the range of the disease is including persistent vegetative state, and also a very severe dementia and irreversible coma, and those specific diseases which is incurable, very unbearable, painful conditions. So Taiwan has more, among our 3 countries, more advanced in terms of legality and in terms of respecting self-autonomy. So Taiwan's Patient Self-Autonomy Act, what that means is that the decision of the end-of-life care is more to the patient, not for the doctors. So if we see the three countries, there are similarities. First, there are legal prohibition of physician-assisted dying. So active euthanasia and physician-assisted suicide is legally prohibited. It's common. And also, three countries have some permission of passive euthanasia. But to me, I think that Japan is more flexible than Korea. I worked with Japanese people when I first started 2002 on stem cell research. And I realized that they're quite different culture. I mean, even we have guideline, we don't keep the guideline, but Japan, guideline works very well for medical communities. In Korea, so there's quite different culture about law and guideline, what means soft law and hard law. So Korea needs hard law. But the current act does not allow us many room for the patient autonomy at all. I mean, very little. So I think the soft law guideline in Japan works more well, and then it gives more room for us to help patients decide for their end of life than Korea's act law. So the difference is we can see that the soft law guideline currently work for the end of life decision in Japan. And Korea has very narrow, narrow margin of decision, very hard. So we cannot decide for really persistence-based state patient. We cannot decide. So we have more, the law and the legal system is kind of compromised between hard debate among religious people and patient group. And after long debate, we made very narrow margin of self-determination. But you see what happened after 5 years of that advance directive, 2 million people, they registered for advance directive. Do you know why? They said, and then the proportion is women's are much higher than men. And then the reason why, the decision to quit the end-of-life care is hard. So I don't want to make my family, my beloved family, to have burden to decide this hard decision. So I will make it for my family. So it is kind of self-autonomy act, but actually those people who registered for advance directive is because they love the family. So it's very interesting to see these East Asian countries, the familyism and family-centeredness still works very hard. And then I think Taiwan case should be, to my opinion, is adopted in Korea as well, because Taiwan accomplished the legal, established a legal framework to make patients exercise their autonomy. So that is my end. Thank you.
Thank you, Professor Kim. I think see quite accurately the criticized our current problem of end-of-life decision-making act, and also the very accurately compare the three countries, the current state. As you know, especially in the international conference, the finish time is very important and crucial. So I would like to have the questions from the audience. However, we already the finishing time. So I would like to invite the three speakers just to comment on the their individual countries, focusing on the we use the different terms, meaning that medical aids in dying or physician-assisted the suicide and the physician-assisted dying. However, it is the same meaning. So the just to focus on the medical aid in dying, please each speaker's comment briefly. Please start from Professor Lee. 1 minute each speaker.
I learned much from our colleagues from Japan. Yeah, I learned much about this important issue from our colleagues from Japan and Taiwan. And as for about medical assistance in dying or MAID, I would emphasize the important and also the problem of autonomy. As the Professor Kim mentioned about the sacrificing themselves, their own good for the good of the family, but it concerns me that it might not be the act of exercise of autonomy. It pushes them or put their own understanding or put their own the autonomy behind the family, not front. At least at the end of life, as whether it is asking for death or asking for more care, whatever the patient wish or informed wish or informed choice must be respected, and also it must be searched. What do you really think? What do you really want to do at this phase? Okay, and once again, I thank for the organizer for inviting me this wonderful chance. Thank you.
Thank you. Now I would like to invite Professor Higuchi for your comment.
Yeah. Thanks, and thank you very much for my present chance to say something, even though the time is very limited. I have learned a lot from the other persons excellent presentation from two countries, Taiwan and South Korea, and I have learned a lot. Thank you very much. I just say the basic facts about the aging society in Japan is this fact. In 2000, 1 million people died in Japan. But nowadays, 1,500,000, so 1.5 times persons die every year. So the end of life care, what should be done is very, very serious issue, including the PAD, physician aid dying, which will not be legalized so soon, I believe, but that's a very serious issue, I believe. Thank you very much.
Thank you. Now, Professor Lin.
About Professor Gao's question about, regarding terminology, I think patient-assisted dying may be more appropriate, because for the concept of euthanasia or assisted dying, we should consider the patient's wish. And some aging population or the patient with severe morbidity, the euthanasia can be categorized according to their wish. So they can be defined as voluntary, involuntary, or even some patients have no conscience. They cannot have chance to express their wish or desire. So I think dying is more appropriate than suicide. And from the experience communicating with our family doctor experts in this aspect, they mentioned that there is one Taiwanese study investigate how many oncologists have the experience to deal with the patients or families' requests about the PAD. The percentage is unexpected low. Less than 50% of the physicians have the experience to deal with this problem. However, from the patient's perspective, actually more than 80% of the terminal cancer patients suffer from the disease, have the idea to request for PAD. So it's have a diversity point of view between patient and physician. Thank you.
Thank you. As a closing remark, I would like to say that as an aged society, dying at home becomes a very, the important issues in all three countries, and for the proper dying at home, medical, aid to respect rightly patient autonomy is very crucial. However, when we make an issues regarding to the physician assisted dying, we should also consider how to protect the patient autonomy rightly. So in the Confucian culture in three countries, family dominance is quite prevailed, especially in the medical decision making, as you already indicated. So usually the patient himself or herself do not express well their autonomy rightly. So we usually talk about how to respect, but not too much how to protect patient wishes. So it should